let me know when you want to change the slides, and you are good to go.
She does.
Okay, so our presentation is on ginseng. Next slide. Okay, so the history dates back to a Chinese emperor named Shen Nung, who he was believed to be the father of Chinese medicine. But he supposedly discovered the effects of this root while he was chewing on it, but he advocated for the use of it for erectile dysfunction. The name of ginseng is derived from the Chinese words gen and shang, which means man herb, because if you look at the way the root grows, there are little spots that grow out of the sides of it that looks like a little human body with arms and legs. Next slide. Okay, so some benefits of this root is an improved physical and mental stamina. It fights tiredness and increases energy levels. It's believed to improve sleep quality. There's a possible benefit to diabetes because it is believed to help lower blood sugar. Again, with the decreased erectile dysfunction, increased longevity, it boosts your immune system, increased appetite, potential benefits against cancer because of it being a strong antioxidant. Next slide.
Okay, so components of ginseng. So like if you break down the plant, within the plant, you're going to have like different essential oils that you could extract. Has antioxidants, the polyacetyl, however you say that, polyacetyl alcohols and peptides, and it has amino acid, polysaccharides, and vitamins. So that is what's in it if you break it down. So we just want to say natural does not always mean safe. So it does have side effects. Some of those include like nervousness and insomnia and changes in blood pressure. It can cause breast pain, vaginal bleeding, vomiting, diarrhea, and mania. And then it's contraindicated in people that pregnancy and children, and it has a high risk of like kind of pushing you into like a manic state. So you want to be careful and not take it if you have any like psychosis or manic disorders. You also want to watch out for hypertension because it can increase it. Asthma infections, organ transplants, recipients, it can interfere with the immunosuppressive therapy and the hormone-sensitive cancers. And then just the same thing. So with the hypertension, you want to pay attention to the cardiovascular disease, and then also cautiously in diabetics, because if it is going to lower your blood sugar and you're already on things, then it can make it go more hypoglycemic. Patients receiving anticoagulants, you should watch out, bleeding disorders, and again, the schizophrenia, the mental disorders. Next slide. So then there's lots of different forms, and people drink it, and like it can be many things. So it can be peeled and chewed raw, and they'll like they'll soak it and they'll extract the stuff raw and then drink it in a tea. And then it also can be dried out and then like boiled into things. And one thing that they'll dry it out and they have it as a big ingredient in energy drinks and teas, because it has that kind of sympathetic response of increasing your heart rate. And it's in lots of Asian cuisine. Next slide.
Okay, so to take ginseng as a supplement, it's suggested that you talk to your doctor if you decide it's something that you want to start implementing. Your doctor can give you some guidance as to dosage and also any side effects like what we talked about previously. There have been some studies that suggest that extended use of it can decrease the effectiveness. And for that reason, it's suggested to take in cycles. So for 2 to 3 weeks, you'll take it, and then you'll take a 1 to 2 week break in between, just so that you don't build a tolerance to it. And like I said, there's various different dosages that are suggested depending on the benefit you're trying to get out of it. And most forms are capsulized for your convenience, but there's also different forms like Chelsea talked about with teas, oils, and topical creams. Next slide.
Okay, so there are some laws and regulations around ginseng just because it was being harvested a lot at one point. And so in 1975, it went on the sites. So it's just basically in Appendix 2 of the Convention on International Trade um, of Endangered Species. So, which just basically regulates the harvesting of it. And so it's able to be harvested in 19 states. And then in 18 of those states, it must be harvested from plants that are 5 years of age or older. And it has to be harvested during the designated state's harvest season. So it can't be harvested out of that. Next slide. So, so basically, to determine the age of the plant, so you count the number of leaves. And so this picture shows kind of a diagram of how to do so. And so they said that about 3 or more leaves is about 5 years old. So that would be how old the plant would be. And then you also count the number of stem scars on the rhizome or the root neck of the plant. And then the root is the active herbal remedy that is harvested. Next slide. Okay, so for our learning activity, you guys can say it out loud in class, or you guys can say it in the text box here in the online. So you basically just have a 56-year-old male that was recently diagnosed with diabetes. He's been taking ginseng for erectile dysfunction. And so we just want you guys to share some things that you would either educate the patient on or what he should look out for. And so, yeah, that's our learning activity.
Anybody?
Corby, I think you're muted, so I think we just, if anybody's saying anything in class, we can't hear it.
I'm saying. Okay. So they said to check with his doctor. Insomnia.
Interactions with what he's taking, his meds and ginseng. Yeah, other meds mixed with the.
Yeah, check for drug interactions.
Other herbal meds.
Pay attention to blood sugars. That's a good one. Melina, you said the same thing. Changes in blood pressure.
Yeah.
Anything else? Heart rate. Just always talk to your doctor. Kind of the takeaway. If you're taking anything, just talk to your doctor about it.
Good job.
And I really like Brooke's comment that it's natural. Natural is not always safe. And ginseng interacts with a lot of medications that actually do some things, but it kind of messes it up. Especially if he's taking it for erectile dysfunction. We're going to talk about some other kinds of medications today that affect this in that arena.
That wouldn't go with his diabetes too.
Yep.
Right. Okay. Good job. There's the references, guys. Let's see. Okay.
Hey, Corby.
Yeah.
Just an FYI for you, the presentation for today for you guys is not loaded to Canvas.
We changed it just like about 15 minutes ago. That hopefully will help understand. It's my fault. So we're going to look at it right now, but give us just a second to make sure, and then pull up the new one. We took out the old ones.
Okay,
I know it pisses you off, and I'm
some
sorry.
slides.
This is a work in progress. It's me, but I think it's going to help you understand.
Okay, let's see. What am I wanting to do?
Next week, it'll be better. Okay.
Share a screen.
It takes a lot to piss me off, but that's not true. I probably got it. I'll still piss.
And we want to get to the point
Slideshow.
where you can print out your PowerPoint and you can take notes from that.
Oh, Amy, I'm trying to get this. Okay.
It's all good.
Give us 2 weeks. Give us 2 weeks.
All right. So now we're going to do garlic. We've got Amy, Maya, and Sydney. Amy's here in person. Maya and Sydney are not. So
Yeah.
we'll
so
just start. Go ahead.
Like Corby said, it's me and Sydney and Maya. So the history of garlic, basically you can find evidence of garlic everywhere, all the way back to Neolithic times, like pretty much on every continent. I think the originated in Siberia. In Egypt, like they used it from the nobles to the slaves. They used it medicinally, spiritually. They even found like sculptures of it in tombs and things like that. So then they have it in medicinal books going back to the 1660s. They used it as a cure for smallpox and the plague. And they also used it in both world wars for an antiseptic and as a dysentery cure. Next slide. Yeah,
Okay, so how can garlic benefit your health? So there's several things that it can do. It can help boost your immunity. And also when you use it topically, it can work as an anti-inflammatory over like any muscles or joints. It can also help reduce blood sugar levels a little bit, whether you have diabetes or not, before you eat a meal. And garlic has a compound called allicin in it, which it's believed that it can help expand your blood vessels, so it can help lower your blood pressure. However, you have to consume like 4 grams of garlic a day to actually like prove this theory that it will lower your blood pressure. And allicin is also what gives it the smell that it has. And then garlic also has a joine. I don't know if I'm saying that right, but it's got a joine in it that can help treat ringworm. And it can also treat other like athlete's foot and fungus and stuff like that. Next slide. So there's several different ways that you can consume garlic. If you're going to take it for health purposes, it's recommended to do it like take it raw. So you can put it in a salad. You can make garlic toast. You can eat plain cloves of garlic if you feel like it. You can make garlic tea, and you can add like lemon or juice or honey to it so it doesn't taste as bad. If you are going to cut it up or crush it or something, you need to give it a minute after you cut it up so that the allicin can have time to start working, so that it'll actually like have the benefits you want when you do consume it. And then also heating it above 140 degrees will kill the allicin, so it won't actually have the benefits you want. So try to add it at the end of your cooking. And then instead of consuming it, you can use it as like a gel or a paste, like I said earlier, for inflammation reasons. Next slide, but it can be sensitive too. So a few things to be wary about when you're using it. If you are already taking blood thinners, then taking garlic can make it more, make your blood harder to clot. So it can increase your risk of bleeding. And then if you just like start consuming too much garlic too quickly, it can make you uncomfortable. It can cause bloating, nausea, diarrhea. It can lower your blood pressure, so beware of that. And then if you are like handling garlic all the time, it can sting your skin, and then it can also give you bad breath and body odor. Next slide.
Okay, so this is the list of garlic interactions. There's a lot, so I'm not going to go through all of them. But see, like on both of them, that the interaction is the thing that you want to watch out for the most is the bleeding risk. Let's see. The natural product of the drug also talks about the effectiveness. It can decrease the effectiveness of contraceptive drugs and cyclosporin. And then it can also decrease plasma concentrations of sanquinavir and some others. And it can decrease isoniazide levels by 65%. And then like over here, the natural product interactions, like some of those are not very common, but like ginger, the ginseng, onion, there was another, turmeric that we talked about previously. Like there's a lot of interactions that can increase the bleeding risk when you're taking garlic. So you have to kind of be aware of all that. Next slide.
Okay, so Kylie, just real quick, wants to jump in, and she says that people with immune disorders have to be really careful using garlic because their immune systems are already in overdrive. And so I don't know if maybe I jumped the gun there. Maybe I should have started wait until you were done.
So just some other interactions. Like we were talking about, just barely, garlic may increase how quickly medications like sequinavir are metabolized, which is used for HIV and AIDS. And so that kind of plays into the autoimmune diseases that Kylie just mentioned. And it also affects isoniazid, which is an antibiotic used for tuberculosis. It may reduce how much of this medication is absorbed in the body, which ultimately reduces how effective it is. Next slide.
Okay, so components of garlic. It's an herbal supplement. It's not regulated by the FDA for medical conditions. It is a therapeutic lipid-lowering agent, and then it just talks about the dose and route here. You can take it by mouth. You can have fresh garlic. You can also get capsules, tablets, or you can take it topically, as we've mentioned previously. So, next slide.
So those are just our resources, and then we have our learning activity on the next slide. And so just feel free to comment in the chat box or raise your hand in class, but we have 2 questions. Is there something about garlic that you would apply in your practice or make sure to watch out for when using it? Or have you or someone you know used garlic for something other than cooking?
Keep vampires away.
Yeah.
Yep. Vampires, of course.
That's how we need garlic.
That's awesome. But okay.
Ears, Chelsea, expand on that.
Yeah, for ear infections.
Oh, ear infections?
Yeah, I'm gonna stop because I hate typing. But yeah, I'll take like oil and a little bit of garlic juice, and then like warm it up and put it in the ear to help soothe an ear ache or ear infection. Don't know if that's allowed, but I've done it. And it helps.
So put it directly in the ear?
Yes.
I think any mixture with garlic is horrible. Maddie. But hey, if it works.
Okay. Kylie had mentioned that you shouldn't take it if you're immunosuppressed, but isn't this boosting the immunity? So why
Ew, and vinegar.
boost?
She said people who already like immunity, like they're overdrive, not suppressed. People who have immunity that's already in overdrive. But it's not like they're already boosted, and then you take another booster. It's like, yeah, that's like a thing. Like you can have too much immunity. Well, people who are on like
well, you can stress the body out too much.
And remember, none of this is regulated. None of this is regulated. So you have no.
I mean, I guess I can just talk. I didn't really want to talk in front of everybody, but it's okay. So my sister has lupus, and her doctor just says that because her body is like constantly fighting itself, and her autoimmune disorder is just like her immune system is so in overdrive all the time, that if you're taking garlic and it's boosting your immune system, you're just doing so much. And it means that like if she actually gets sick, like her body doesn't know, because it's just constantly in overdrive all the time. So if she's taking garlic, it's just going to do too much. Does that make more sense?
Yeah, Braden said the exact same thing.
Yeah.
Okay,
So remember,
everybody.
autoimmune diseases, the body is attacking the immune system. So if you bring something in that helps the immune system, the body's going to attack it more. And that's what Kylie was talking about, how her sister is, you know, the body's constantly fighting it because now you have even more immunity and it's fighting even more, and it's in this constant upheaval, especially with lupus.
Okay, perfect. Thanks, guys. You guys want to take like a 5-minute break or just jump right into it?
So we did post the new PowerPoint. And again, I apologize. It's completely my fault. I had a thought this morning that some of these images that I pulled up would help you in understanding when we're talking about left-sided and right-sided heart, and when we're talking about the effects of adenosine and some study helps. Okay, so again, I apologize. It is my fault. I'll be more on the ball here so that you can print out your PowerPoints. When I was in this program, I did that. I printed out like 3 pages or 3 images with lines. You can do that. And I just did it at the print center thing here. And that way I could make notes, because we didn't have this glorious thing where you could like record it, and everybody had to come to class, it was pre-COVID. And so you can make notes on those specific ones, kind of like when you're in biomed or anatomy and physiology. So, sorry.
Do I just jump in? Okay. Good, because we've got a lot to.
It's on the very last one.
It's very at the very bottom, because we just barely added it in Unit 9. Is everybody finding it okay?
For those who have printed the previous one, we'll add another file with just the ones added. So don't feel like you have to print it all over again, because we just added.
Yeah, it's only 5 slides.
5 slides.
That's all.
I don't think we changed anything else, did we? I don't know. We'll see. Okay, so there's your learning objectives. They're there or in your syllabus. Now, I am only human, so if there's anything that's discrepant between this and the syllabus, go with your syllabus, please. Okay. You're up. Did you want to do this or did you want to do that first? We can do that first. Okay, sorry, real fast. Going back.
Okay, so all of you in that survey, for those that did respond, identified the ways that you learn, okay? And so what I did last night, and we talked about yesterday in terms of the hours that it's going to be required for you to be successful. And if you remember, I said, if you're not studying to pass the test, you're studying for the day that when you are the only one between a patient and the grave. And I have a story about that today, so we'll get to that one. So I don't know. Where are we at? No. It's at the top of the.
I'm trying to.
We'll just go to
stop sharing.
Like here. Okay. So anyway, so in an hour and a half last night after my hubby went to bed, because right, isn't that what you do after you put the kids to bed? I printed out a few things. So you have to find a way to break down this massive amount of information that's in the chapter, okay? It's kind of helpful if you could even review it 30 minutes before you come to class. The best is to kind of review it, the night before, but I understand everybody's studying for the test. So there's 4 different kinds of things, okay? If you're a visual learner, then this is the disorders, okay? I just printed this off from the internet. This is what they call concept maps, okay? But they're brain concept maps, sorry. They're brain concept maps. These are the disorders we're going to talk about. I put each one in a different color, okay? If you're a visual learner, this will speak to you, okay? And then continuing on, I did the purple, which is angina, okay? So then I broke down the anti-anginals, the medications that go with it, okay? All the different nursing, things of this nature. It's on the PowerPoint, there it is. And then a concept map, which is already in your module under study helps, way at the top of it, that actually is a concept map of a medication, okay? And you get it, all this information came from the book, okay? And of your therapeutics, what you do, nursing, teaching, okay? So you can do this for each medication of the prototypes. it doesn't matter. If you're a reading, writing person, you know, this is where this and this is where you live at. Okay. If you are kind of a kinesthetic learner and or you can't really handle large amounts of information at one time, use a storybook so that you can put one thing on it. So it could be, okay, left-sided heart, this is what's going to happen. This is what I need to look at. And you can actually draw, okay? If you are kinesthetic and you need to be touching and moving things, then put them on 3x5 cards, okay? And you pull one out and you match it with what is in your brain, how your brain functions, okay? But you have to break down this information. If you try to encompass it in a whole thing, you're just going to go down a rabbit hole and you're going to get really upset because it's like, I can't remember all this much. It's not remembering the specific information it is, but it's taking it and applying to a patient that you're taking care of. Does that make sense? Is any of this helpful?
Yes.
Where are these at?
Yeah.
Where are these at?
Yeah.
Okay, if you feel that they're helpful, I will load them onto Canvas for you.
They'll be under study helps.
The blank,
Yeah,
Module.
the concept map.
Yeah, so one of the
So
concept
what
maps
is it?
already on there.
Yeah. So this one is already on the study helps. It's
Yeah,
great.
this one.
This is great for your meds. Great for your meds. Okay. The other things, this is a storybook template, and I can load it onto the Canvas. It'll be under the study helps. Okay. And then these are just free templates that I found. If you like something like this, I'll put it up there. Yes, no?
Yes.
We'll put them all up there. You can
Okay.
decide to use them or not.
And you can Google concept maps. See if you have Pinterest or whatever. There's tons out there. Find one that works for you, that speaks to you. Okay. Had a student today say, oh, I put down the classification of drugs and that this one was for this one. Great. Okay. You can even put them on 5x7 or 3x5 cards. Okay. Matching. So that it gets inside. The more that you do, the more it will make sense. And hopefully today you'll see that. Okay, that's all.
Okay. I believe this cord is not long enough. Okay, let's see.
Tell me who came in.
Mark.
So tell me your name.
Mark.
Okay, Mark what?
Richards.
Okay, sorry.
Mark with a C.
Go ahead.
And then Jenny.
Jenny. Oh,
Okay,
you were alone. Okay.
so we are talking about the heart, right? Wait, back here. We're going to do cardiac glycosides and anginals, however you want to say it, and anti-dysrhythmias. So we need to review the heart. So whenever, you guys should probably already know, whenever you're looking at the heart, you're looking at as if it's in a patient, right? So like if this was my heart, this is my right side, this is my left side. So you're always looking at it like you're looking at it in a patient. So you've got your right atrium. This comes from your peripherals, right? Comes through. Right atrium, goes through your tricuspid valve. Then where does it go? To the lungs, both sides, right? This guy over here. Then it comes back through the pulmonary veins, thanks, Mark. Into the left atrium, through the mitral valve, through the left ventricle, and then out through your aorta. Okay. So that is a healthy, normal human heart. Here is an interior view.
Okay, and this is really important because the heart
with the electrical system
is a muscle and it has two different functions. The electrical system of the heart is what actually contracts the muscle. Okay, and that's what we're talking about. Can I throw this? And that's what we're talking about.
Yeah.
Their city can't see it.
They can't see
Can't
the.
see this?
Yeah, the PowerPoint isn't on screen share.
Okay, hold on. I'm
Sorry.
I'm doing it.
We're technically disadvantaged. It's my fault. But hey, I decorated my door. Come see my door.
How's that?
That's great. Thank you.
Okay.
Like a pumpkin skull.
Sorry, guys.
And it's lit. So when you talk about the electrical activity, okay, this is your SA node, also known as what? You learned that 2 days ago? Spinal
Quick
atrial.
question.
Huh?
I'm sorry. Can we make the camera so like we can see her when she's pointing at things on the screen? If she's pointing anything?
Yes. Give me just a
We've
second.
done that with the last class. It just really helped to be able to see.
Yeah, I'm gonna go get a portable camera. I don't have one on my. So keep going over.
Oh dear God, I hate being on camera. Okay, so the SA node, you can see in the picture, right? For those of you who are online.
Debbie,
Yes.
you can just turn her computer to face you and they
Oh.
can see you in the meantime. Yeah, just put it towards as long as she has her camera on.
I don't think she does. Can you see me?
Yes.
Oh.
Yes.
Okay, so just turn the camera. Can you see the board from the camera?
How about Chelsea?
Is that a yes?
Yes,
Yeah.
we can.
Okay, all right. Can you see me?
Yeah.
Okay. So the
Thank you.
SA node, this is the electrical system of the heart. This is what causes it to beat, okay? And this is the heart's pacemaker. This is what's every 60 to 100 times a minute, this thing goes. It sends electrical things down into here, into the AV node, atrial ventricular node, and this, I love this, the bundle of His. Okay, this goes down each side and then contracts. So when you have, this is called Purkinje fibers, those are the things that contract the heart. So when you hear about left bundle branch block, you heard that? No? Not yet? Did they go over that in the last couple of days? Okay, same thing. You hear when you go to class or when you go to your clinicals, right? He's got a left bundle branch block. Everyone goes, ooh. Okay, that's what they're talking about. There's a problem in the conduction on the left side of the heart. Okay, and it looks like little bunny ears on EKGs. All right, so when the heart gets a problem, it can either have a problem from the electrical system or it can have a problem from the pumping system. Because when this contracts, blood is coming through, right? And then goes to the different parts that we just talked about. So there's two kinds of problems that the heart can have. One is electrical, one is actual pumping. And the medications we're going to talk about today, some affect the electrical, some affect the pump. Okay? You got to get that one separated. Or you're going to go, what? And then that little emoji, with the brain exploding off the top, where are you going to be at? Okay? Questions? Do you have to know all of this? You already should know this. This is from anatomy. This is from biomed. Okay? We're more in the pathophysiology. When this goes wrong, what can we do to intervene? And that's where medications come in. That's where non-pharmacological things come in. That's when herbal stuff comes in. Okay? Yeah? We're good?
Yeah.
Okay. Are we good online? No? You got to tell me. I need to hear you.
Yes, we're good.
Okay. Now, how do I do this? Anybody know how we go to the next one? Oh, okay. It's her thing's buzzing. It's not me. I'm sorry. Hang on. Okay, hey. Okay, this is a very, very important slide. The one on the right is very, very important because that's where we're talking about left side and right side heart failure. Preload, afterload. You have to think of the heart as kind of like a dam, okay? If something's going wrong on the right side of the heart, you're not going to get as much blood flow into that, right? Okay, so where's things going to
I can't hear anything anymore.
I can't hear anything either.
Barbie, can you turn on the volume? We can't hear. So we've been missing all of this.
I don't think we can hear because of the camera, but I'm pretty sure all of us were fine with the laptop just at least facing Debbie. Like that's all we needed was just for the laptop to face her so we could see what she was pointing at.
Well, you've all seen a six-pack that looks amazing, right? Perfect. You know, you've seen those bodybuilders and they like get all this, okay? Well, when the heart has to work harder, it's not good because the heart has nowhere to go. It's in the mediastinum, it's surrounded by membranes. It can't expand like your deltoids can, your trapezius can. And then that's where we get into problems, okay? Sorry, I just kind of carried on. Questions?
No, you're fine.
Comments? Let's go to Corby.
That's fine.
Well, I don't think it's recording, but because it wasn't recording the volume, I think it will still be cut out, whatever she said.
Okay. What do you need me to tell you again? What did you not get, or what did you hear?
I don't think we've heard anything since the last slide.
Okay. So we'll say it again.
Well, since I did the camera, though.
All right. Did you disconnect the camera?
Yeah.
Okay. Can you hear me now, and can you see this slide presentation?
Yes.
Okay. So the most important thing, preload is right side of the heart. It's blood that is coming in from the body. So if there's a problem with the right side of the heart, where are you going to see the effects in the body? Say it louder. In the body, yeah.
In the peripheral.
Yeah. We're going to have another slide coming through. Because it hasn't gone to the lungs yet, has it? Okay, so the left side of the heart, which is called afterload, if it's not functioning, where are you going to expect to see problems? In the lungs, as well as the rest of the body, because it's trying to pump blood to the body. All right, so it's in the aorta. If you don't have enough blood going through the aorta, are the kidneys going to get perfused? are the extremities going to get perfused? And you're going to see this as we go along in lecture. Does that make sense? Are we clear as mud?
Your heart pumps blood essentially to two places. The first place is your body. So you have your oxygenated blood on the left side. And we got to remember that the left and the right are switched because we're looking at the anatomical view of the heart. So it pumps it out to your body, and your body gets that oxygen. Your body uses it up and then circulates it back into the right side, where this time it's pumped out to the lungs. It gets reoxygenated. It gets that oxygen back, and then it's circulated back to the left side. And the amount of blood at any time pumped to your body is sort of based on this demand that your body has for blood. You kind of think of it like you have this gauge that says, hey, I need this much blood to sustain this much activity. And this can change. So like if you start working out or something, your demands might go up. And your heart can accommodate for that. And you start pumping more blood to that body to meet those new demands. Heart failure describes this condition where the heart can't meet the demands of the body. So at any given time, the heart's not able to pump enough blood to meet the body's demands. And there are essentially two types of heart failure. The first one we call systolic heart failure. And systolic refers to systole, which is the phase of the cardiac cycle where blood is pumped out of the heart. And so systolic heart failure is when those heart muscles aren't pumping blood with enough force. So this often means that those muscles are weakened and smaller than with a healthy heart. And this typically makes it look quite a bit different. When these smaller muscles contract, they don't squeeze as hard as they used to. This causes less blood to be ejected with each contraction. Now I say contraction because the heart's this muscle, right? So when it contracts, it squeezes. You kind of think of it like you have this water bottle that you're holding with your hand. You squeeze the water bottle and it shoots the water out. It's the same concept with your heart. When those muscles contract, they squeeze the blood, and that's how you eject blood to both your body and your lungs. With systolic heart failure, since your heart muscles are smaller, think about squeezing that water bottle again, but just pinching it. It's going to be a lot harder to squeeze the water out, right? Well, it's the same thing for the heart with smaller and weaker muscles. It's going to be way harder for it to squeeze and pump that blood out to the body. You probably noticed that this heart has these sort of enlarged looking lower chambers. And at the same time, it has this really thin muscle wall. These are really characteristic traits of a heart with systolic failure. These small muscles make it really hard for it to pump blood to the body. So that was the first type of heart failure. The second type is called diastolic heart failure. And instead of being a pumping problem with the muscles being too small, diastolic failure is a filling problem, which is why we call it diastolic failure, because it refers to diastole, which is that phase in the cardiac cycle where the heart fills with blood. So with this type of failure, your body's not receiving enough blood because your heart's not filling with enough blood to pump out in the first place. So if we jump back to that water bottle analogy, this time you're holding it with one hand, just like we were for the healthy heart, but instead the bottle's filled with less water. So even if you squeeze it with the same force as a healthy heart, less water is going to be ejected simply because there's less water in the bottle. And this is essentially what's happening with diastolic failure. Since there's less blood filling in the ventricles, even if it's pumping with the same force, less blood is going to be ejected to the body. But why is there less blood filling in the chambers? Well, it's because those muscles are actually larger in this case, and they take up more space. And this leaves less space for that blood to fill into the ventricles. Okay, so far we've shown both types of heart failure, and each time we've shown it happening on both sides. Well, this isn't always the case. It's definitely possible to have isolated heart failure, so maybe you only have it on the left side, or you might have it only isolated to the right side. One important thing to note, though, is that usually a left-sided case happens first, and then that ends up leading to a right-side failure. I know I'm only showing systolic failure here, but I should note that this isolated failure can happen with either systolic or diastolic. So depending on which side this is happening on, the left or the right, the symptoms are going to be a little different. Let's just go ahead and start with the left side first. Since the left side pumps blood out to the body, that means it's coming in from the lungs. And if it's not pumping it very efficiently to the body, that blood starts to get backed up into the lungs. Think of it like a traffic jam. What happens when they close a lane and then they only let one car through at a time? All those other cars get backed up. It's kind of the same thing. This blood gets backed up into the lungs because it's only pumping a little bit out at a time now. So a really common symptom of left-sided heart failure is fluid buildup in the lungs. This is called congestion. And it's also sometimes what I would say congestive heart failure. All right, so that was left-sided failure. Let's take a look at right-sided failure. Again, I'm just going to show systolic failure, but let's just note that this can happen with either systolic or diastolic. This time, since we know that the right side pumps blood to your lungs, we also know that it comes from the body. And since it doesn't pump blood as well to the lungs, we have that traffic jam situation again, but this time it gets backed up into the body. So patients with right-sided failure might start getting fluid buildup in their feet, legs, and abdomen. And again, just like the left side, you have congestion or fluid buildup, but this time it's in your body instead of your lungs. So as a quick recap, you could just have systolic failure on the right side, or you could just have systolic failure on the left side. And it's possible to have both. The same way, you could have diastolic on the right side only, or you could have it only on the left side. Or you might have both. It's even possible to have a combination of systolic and diastolic failure. So now that we've kind of nailed those down, let's talk about this really important way that we measure the heart's ability to meet the demands of the body. And that's called cardiac output. Cardiac output represents the total amount of blood that the heart's able to pump every minute, usually given in liters of blood per minute. And the normal cardiac output is around 5 liters per minute. Now, cardiac output can be broken down into two other components. And the first is stroke volume, which is the amount of blood pumped out every beat, which is different than cardiac output because it's every beat, not every minute. And so we take this stroke volume and we multiply it by your heart rate, which is measured in beats per minute. And those two multiplied together equals your cardiac output. So if you were to change either stroke volume or heart rate, for example, let's say I lowered stroke volume, since cardiac output is dependent on these two variables, cardiac output is also going to go down. And that's what happens with heart failure. Cardiac output is lower because the heart's not pumping as much blood per minute. This is usually because there's a lowered stroke volume or a lowered amount of blood pumped out with each contraction. So usually heart failure is considered a secondary disease, meaning that it's caused by some kind of pre-existing or underlying disease that already affects cardiac output. Specifically, we're going to think about diseases that cause the death of cardiac muscle cells, which are also called cardiomyocytes.
Hold on. I don't know if we need to go any further than that.
You'll go into more of this in your RN.
It gets way worse at pumping
Right
blood.
now, understanding which side of the heart goes where,
This lower stroke volume, and then also
and medications that affect it is where you're at. Okay? Are we doing okay? So this is one of the slides that were added. So those of you who are online, we will post my, my 5 slides. Okay? And this is again what a normal heart is on the left and a congestive heart. Okay? You see how much bigger it is, and see how much those muscles have had to work to overcome the resistance to get that blood out. So because the muscles are bigger, it actually isn't a good thing when you're talking about heart, because then look how much blood is coming out on the congested side versus the normal side, okay, on the left side. So when the heart has to work harder, then those muscles get bigger, but they have nowhere to go, so the chamber becomes smaller. Does that make sense? Okay. And if you want to go into ER and ICU, this is your life. This is where you live.
Or CBTU.
Or CBTU, exactly. You can see this on X-ray. That little bulb on the left is the heart silhouette. That's a normal heart. Look how beautiful those lungs are. Everything's great.
It's like right here.
Like a uvula. Yeah, looks a little bit like a uvula. All right. On the right, this is a person that has congestive heart failure.
Ooh.
Do you see how big that heart is? And look what the lungs are. It's congested. That's fluid. Okay, you'll see that in pneumonia and things like that. So again, you don't need to know what it looks like, but do you see the difference between the clarity of a normal one and a heart that's not doing well?
Well, and if your heart enlarges, what's it going to do? Where's it going to go?
Yeah,
exactly.
Yeah. Look how much lung capacity this patient has. Think he's going to be breathing well? Eventually they do. You're right. That's the reason why your COPD and congestive heart failure, they have these big barrel chests, skinny little legs, skinny little arms, big barrel chest, because the chest is trying to expand, the lungs are trying to expand, and nothing's working well.
So this is a chart that just kind of breaks it down and helps you know the signs and symptoms of each side.
This should be review, okay? Peripheral tissues. So how many of you have seen pitting edema? Okay, and you mark it, right? 1 plus, 2 plus, 3 plus, how far up it goes, part of your baseline assessment. So when you see that, it's called dependent edema. Chances are that should pick off your little brain that says, I wonder what medications he's on. They could have heart failure, okay? What about if you hear lung sounds that are crackles and, things that are going on in the lungs? Might be heart failure. Left-sided, because it's backed up in the lungs.
All right, visual.
And this
pictures
is huge. This is huge.
I know it's a little blurry, but you can still kind of get the point. So you've got, ascites, you've got your peripheral edema, which is going to cause your weight gain, right? Distended jugular veins.
And why would you see distended jugular veins? For what? Okay, it's okay. Remember, this is a safe environment.
Backed up.
Okay, it's backed up. It's backed up in the body. Is that what you're saying? I didn't really hear you. Yeah, it's backed up in the body. It's still in the venous system, okay? Because it can't get through the heart. So they will be distended. And they are so tired. They're so tired. The dependent edema. Now, next unit, we're going to talk about drugs that can help with right-sided heart failure in terms of diuretics to get rid of that fluid, okay? Any of you given Lasix or, that sort of thing? We're going to, because that's interactive with the kidneys. That's all happening next month. And here's just a side note. Everybody, I want you to know, the semester is going to get better. You are at the most difficult part of the semester. When you start talking about cardiac, when you start talking about ICU drugs, your brain just explodes. But I promise we will level out in about 3 weeks. It's gonna level out, okay? You gotta believe me. It will level out. So don't give up. Stay tough. Buckle down. Give it 3 weeks.
Yeah. Okay, so the biggest thing, the biggest takeaway here is on the right side, you're going to see it in your peripherals, right? With the edema, it's all backed up in your body. On the left side, it's backed up into your lungs. So your lungs are going to be the biggest thing affected. You're going to get the cough, the crackles, the wheezes. You might get blood-tinged sputum, depending on how far it is. Tachypnea, tachycardia, the cyanosis, because you're not getting enough. So it does affect the peripherals, but the biggest thing is lungs, edema.
Body, yeah. And they actually will sit like this on the right side. If you've seen anybody that is in congestive heart failure, they sit like this. And we call it tripod. They tripod, because that's what they're trying to get air in. So if you see somebody, one of your, if you work in a SNF or anything like that, and they're doing this, yeah. I'm gonna go get your nurse.
Okay, so what causes heart failure? So in that video, he probably would have gone into it if we would have kept going, but I knew we were going to cover this. So heart failure is most always caused by something else, right? So here we have all sorts of different things: hypertension, an MI, coronary artery disease, valvular heart disease, congenital heart disease, all of these fantastic things. Substance abuse.
Yep, substance abuse causes cardiomyopathy. If you are a Guns N' Roses fan, as I am, Slash, he's the dude with the hat. Because of his cocaine use, he blew up his heart. Okay, had 5, like they said, 6 weeks to live. He changed his ways, got off the coke. He still has a pacemaker, but he doesn't have to use it. Okay, it's legit.
Right. So one thing that's not on here that has been argued previously is kidney failure. What about kidney failure?
Good job.
However, it probably 98% of the time you're going to get heart failure before you get kidney failure.
Remember, hypertension affects the kidneys. We'll get to that when we get to renal. And so the heart, the lungs, and the kidneys all work together. If one fails, it's just a domino effect. Okay? And that's why many of these medications work on the kidneys, work on the lungs, work on the heart. Next week, in your pediatric cardiac, you're going to see the congenital side of it. Because you'll have neonates that have high blood pressure from a congenital heart failure.
Okay, so here is another fantastic flowchart of decreased myocardial contractility.
Learn in a different way.
So I just have all of these. Take what works for you, okay? Don't feel like you have to study off of every single one of them. Just take which one works for you and run with it. That's why I put a whole bunch of different ones in there. Okay. So now we have heart failure. What are we going to do now? Well, there's non-pharmacological ways to decrease your symptoms / risks of heart failure, right? First, there's weight loss. Limit your salt. 1 teaspoon a day. That's not very much.
It's not, especially if you eat stuff out of a box.
Yes.
And why would salt be so important? What do you think? Yeah.
Water retention, which is putting more stress on the heart, right? If it has a lot more volume to pump, it's putting more stress on the heart. So limit your salt. Maybe get non-salted French fries. No, not a fan. Okay, limit your salt some other way. You can limit your salt some other way.
There you go.
A low-fat diet, low-saturated fat diet. Decrease alcohol to 1 drink per day, or the best is none, right? If it gets severe, you might they might be on a oral fluid restriction. You'll see those signs on the doors at the hospital. It says fluid restriction. It can only have 1,500.
You see those signs, you immediately say heart failure.
Yep. Smoking. Stop smoking when you guys said that. And then mild exercise is recommended. Now that's only obviously with the direction of your doctor.
So even after you have a heart attack, they have what they call cardiac rehab. Okay, you may have heard of that. And so they work out the heart, but they don't stress it to the point that you have another heart attack and they have, I'm like, who is this? But they're constantly being monitored in their heart rhythm.
Okay, so the first group of drugs we have with this heart failure problem is cardiac glycosides. They're actually naturally occurring cardiac glycosides in a whole lot of plants. But, of course, with technology, we extract those out. And we have medication now. So the first line of cardiac glycosides are dopamine and dobutamine. What's the problem with using dopamine and dobutamine? What if you were like at home? What do we know about dopamine and dobutamine? Right, with the dopamine, you got it. But they're the naturally occurring catecholamines, right? So if you take them orally, what's going to happen? Nothing. Nothing's going to happen. Yeah, they're going to be destroyed before they get in your system, right? So dopamine and dobutamine can only be given IV. So even though they're fantastic and they're great and they're probably the first choice, sometimes they can't be the first choice. So we go to our second choice, which is digoxin. I'm sure you guys have all heard of that.
This is actually, and unfortunately, because of the book, because it is 5 years old, this is one of your prototypes. But I want you to know this is phasing out. Digoxin is still used, but if you look on the Mayo Clinic in terms of digoxin is not recommended if you take these drugs, the list is as long as your arm. And so they have developed some newer medications that are still part of your prototypes in your book, and one of that's called diltiazem. But it can be used in this, but it also is used more for dysrhythmias, and that's why we put it in the dysrhythmia as opposed to this. But just understand, digoxin is one of your prototypes. You do need to know about it, and it has a very narrow therapeutic range, so you can get toxic very easily. So they're doing levels all the time, so know your digoxin and everything about it.
So it can be oral only, or it can be IV?
It can be oral.
It can be IV.
And IV.
Yep.
So when you talk about dopamine and dobutamine, you're in my world in the ER. Okay?
Or ICU.
Or ICU, or CT, yeah, SU, yeah.
Yeah, okay, yeah. So the one thing with these cardiac glycosides is they will decrease your heart rate. And so the biggest takeaway for digoxin is always check your apical heart rate before administering. And who knows what the limit is? Anyone? The limit of the heart rate to give digoxin. Above what?
I would say 60.
Yes, you got it. Has to be above 60 to give. If your heart rate's 58, don't do it.
That's classified as what? Less than 60? Bradycardia. Yeah, it's contraindicated in bradycardia. How long does it take to do an apical pulse?
1 minute.
1 minute.
1 minute. Do you do it on the wrist? Do you do it on the wrist?
No.
Do you look at the monitor?
Do you do it like this?
No.
Which side is your heart? Okay, so apical heart rate for a full minute. Okay, so these cardiac glycosides, they're used to correct atrial fibrillation and atrial flutter. They decrease the heart rate, like we talked about, decreases the conduction through the AV node.
That's the electrical portion of the heart. Whenever you hear the word conduction, electrical, it's those electrical impulses going through the heart. It's not the pump, it's the electrical conduction.
Okay, so then it increases the myocardial contraction. It'll increase, you're increasing the contraction, which is pushing more out, so it's increasing your cardiac output, and then it improves the circulation and perfusion that way.
I have a quick story about your meds, okay? Remember how you guys do they have to calculate rates?
Like drip rates?
Yeah.
Yeah. Well,
okay.
Yeah.
Do you guys have to calculate drip rates? Okay, so I used to sit in the back and I would bitch, moan, and groan every time I had one of those things because I'm like, that is so stupid because I have a pump. I have a machine. I have a pump, okay? So I'm in my preceptorship, all right, on IMC at Ogden Regional, and we had a guy come in that we had to put on a dopamine drip. And they were thinking he had a stroke, and we had to take him to MRI, okay? Well, the MRI, that pump does not work in the MRI. And there was a charge nurse and 2 other nurses that they called over to ICU. ICU's like, just calculate a drip rate, click. And they're like, what? How do we do this? I haven't calculated a drip rate. And I was like, oh, shiz. They were right. Because I was always bitching about my pharmacology instructor, because I'm like, this is not true. I was the only one that could calculate the drip.
We have pumps.
I know, exactly. I was the only one that knew how to calculate a drip rate. Why? Because I sat in a classroom and had to do it on tests. So never say never. Never say never.
I bet you have, and you just didn't know it.
Go ahead.
Are all of the cardiac glycosides, those are all like electrical part of the heart?
They're used to help the heart pump better, just like it says. So it decreases the conduction through the atrial ventricle, the AV node, which is in the middle where it starts to go off, and it helps increase the ability to the heart to pump. Go ahead.
So you're saying it increases like the heart functionality, but why would it increase the heart rate? So is it going in there and able to help it pump blood better?
Yes.
So it's just helping the functionality rather than.
Yes. And this is where, what are you going to have to do to digoxin, people? No, like, what are you going to need to know about digoxin? Everything. Okay, and that's where the concept map comes in. Okay, what does it do? How does it affect? What's therapeutic? What's contraindications? Go ahead.
So how are you classifying on that? If technically it's a cardiac glycoside and it's an anti-dysrhythmic, so how are you classifying those if it's both?
Look in your book. Let's open your book. Where would you find it? I think it is.
It's on the cardiac.
It's a cardiac glycoside.
Yeah, glycosides. What page is that?
534.
Okay.
534.
Okay. So let's open it and find that answer out.
Every
Because
single one is just sending you the prototype, which the prototype is listing as a cardiac glycoside.
right.
But it's still classified under an anti-dysrhythmic.
You're right. And so does diltiazem. Diltiazem is a dysrhythmic. It's also used for hypertension. It's also used as in heart failure. So so those are the uses of the medication. But for the cardiac glycosides, we're utilizing digoxin. So it's that pathway, that cardiac pathway, where digoxin would be used as a cardiac glycoside, not as a dysrhythmic. Yes.
Yes.
Yes. Yes.
Uh-huh.
But part of what you learn about digoxin on your concept maps is that you can see it in other heart issues. Does that make sense? Okay.
So what you're going to find as we go through this is we're going to talk about meds over and over again. The same meds are going to be used as anti-anginals. The same meds are going to be used for dysrhythmias. It's just going to repeat. It's all the same meds, just kind of used different ways a little bit.
For the condition.
Go.
Okay, so I just need a little clarification. So you said that you have the conduction, which is going to be the electrical, and that's going to control the electrical impulse of the heart. Then you have the muscle that's going to control like how much blood is going. So would this be more electrical or would it be muscular?
It's both.
It's going to be both. So there's not going to be a specific category.
So digoxin, these cardiac glycosides in digoxin work three different ways.
Okay.
They have a positive inotrope, which increases the contraction and the stroke volume.
And you're on what page?
534.
Okay, so if you haven't read your book, you're asking questions that are going to be answered by reading the book.
Well, I just wanted to get.
No, I'm just saying some of these questions are going to, do you see why it's kind of would be helpful to just take 30 minutes and kind of look it over a little bit? You really want to be on the ball, do an hour. But yeah. But so, you're right.
We have the increased myocardial contraction.
So open your book, 334, because this is how you're going to answer that question.
It also decreases the heart rate and it decreases the conduction of the heart cells. Okay, so three different things that it does all in one. And that's how we control this atrial fibrillation or atrial flutter that's happening.
Because remember, fibrillation means it's not pumping, it's just fibrillating, it's just shaking.
Yeah, it's just shaking.
And you got to get it to pump.
So the goal ultimately, obviously, is to convert this into a normal heart rhythm, right? We want it to be able to pump efficiently. If that's unable to happen, then the goal is reduced to just slowing the heart rate. Because atrial fibrillation and atrial flutter, I mean, they're like going crazy enough that it's not pumping hardly anything. So we just want to slow that down so it can pump more efficiently.
Might be a stupid question, I'm gonna ask it anyway. So,
Good.
All we have to know about dopamine and
Dobutamine.
is just that it's gonna be IV because the liver will deactivate it and that it's a cardiac glycoside? Mm-hmm. Okay. So
Yep, that's it.
More about it.
Yeah, we are focusing more on digitalis, but okay. Sorry, I gotta go. I wish we had more than one screen on here. Okay.
Sorry.
I love it.
Also, while this is loading, we had a thought, because I know a lot of you are looking at YouTube videos to help. I'm going to put up in the discussion post, and it'll say helpful videos for future students. Would you be willing to kind of share, or just the links of those that you have found to be helpful as you study this unit? That's okay. Just give me your top 3, okay? Because we're talking about 3 different things. We're talking about 3 different pathologies. Just the 3. Would that be all right? No more than 5 minutes. I'll put it in terms of what the things are.
This has nothing to do with blood pressure. So we have no orthostatic hypotension and no slow position changes. Here's a positive inotropic drug that gives a deep contraction or increases contractility. So think digoxin digs for a deeper contraction, usually given to patients in systolic heart failure or that squeeze heart failure to help with a more forceful contraction. And also it decreases the heart rate, aka negative chronotropic. Chronos meaning time, so negative time we get less beats per minute. But guys, caution, this is very toxic. So think digoxin is a toxin. The top 3 NCLEX questions will always include our memory trick, ATP. A for checking the apical pulse for a full 60 seconds. If the heart rate is less than 60, guys, it gets a little risky.
A lot of risky. A lot. It's a lot of risky.
Mr. Anything. Ooh. Okay, guys, focus. The apical pulse is located left side mid-clavicular in the 5th intercostal space. Basically between the ribs. You got it? Okay, good. Now,
is that Tatum Channing?
Channing, yeah.
Tatum, sorry.
Over 2.0 is huge. Early signs.
You guys will need to know this.
This is part of the laboratory values.
Guys, we want to notify the doctor ASAP. Huge NCLEX concerns. Now, another concern for vision changes include words like fuzziness or even blurred vision. Even color changes, guys.
That's big too. Know that.
You were here. Difficulty reading. Now that one really surprised us in our NCLEX review. I was like, really, like vision changes for reading? Tricky. Not today, Mr. NCLEX. Not today. No surgery. Now a big test tip and side note about that big old kidney behind me. Guys, older patients with decreased kidney function are at higher risk for toxicity, our digoxin toxin. Since the kidneys are kind of like our washer machines that wash the blood, that broken kidneys means it can't wash the drug out of the blood. So remember, we have 2 kidney labs for our 2 kidneys, both BUN and creatinine. But the number 1 kidney lab is, guys, write this down, creatinine. Any value over 1.3 means no PP, or basically over 1.3 means kidney injury. Huge risk for toxicity for any drug. So guys, we monitor our elderly and renal failure patients very closely. Lastly, checking potassium level. Any low potassium below 3.5 increases the risk for digoxin toxicity. Now, this does not mean that digoxin can cause low potassium, like diuretics. Guys, low potassium only increases the risk for dig toxicity. Now, the NCLEX will try and trick you. So again, digoxin does not waste potassium. So no, you don't need to eat more green leafy veggies or melons like when taking thiazide or loose diuretics that waste potassium. So guys, don't get tricked. Now to help you, a common test question. Here it is. which patient is most at risk for digoxin toxicity. Guys, it's always either reliant on potassium-wasting diuretics, like those ending in I, like furosemide or thiazide.
We'll talk about those next week.
Kidney failure signs, with creatinine over 1.3.
Okay.
Did that help?
That has a lot of really good information to know.
Who's in it?
His newer videos, yeah.
The nurse, Okay, so here's our nice chart about digoxin. Definitely there's your antiarrhythmic. Anti-dysrhythmic, anti-arrhythmic, used interchangeably. Even though they do have slightly different meanings, they are used interchangeably, okay? In our heart failure, it is a cardiac glycoside. This is a mechanism of action. It inhibits the sodium-potassium pump and causes an influx of calcium. What you need to know is what it does. It slows the heart rate. It increases contractility and decreases the conduction. Okay, side effects, amongst others, you have your normal nausea, vomiting, diarrhea. Toxicity, this is what you guys need to know. Vision changes. If they're blurry, if they have color changes, usually if things start turning yellow or green for them. Okay, if they start getting halos around objects that they didn't have before. I know some people get halos at night anyway, but that's really important. Bradycardia, and then any new cardiac dysrhythmias. Okay. One thing in this whole section, and we'll talk about it at the very end, is that these drugs that can help dysrhythmias can cause dysrhythmias. One of those great things.
That goes back to the conduction, the electrical things, messing with it.
Okay, there's your contraindications. Obviously, bradycardia is on there. If you have bradycardia, don't give it. That's why we check the apical pulse. A lot of drug interactions. Here's only some of them. Now, the potassium-sparing diuretics. Now, remember, digoxin does not throw out potassium, right? It's not potassium wasting. But if you have low potassium, you have high risk of toxicity, which is really important, okay?
And that goes back to chemistry, how the drug breaks down, what it latches onto, and which allows it to perform.
Multiple CAMs, of course. So with nursing, you'll want to monitor your side effects really closely. Monitor your digoxin and potassium drug levels. Take your apical heart rate before administration, not during, not after, before, please.
And many times when you're documenting that you're giving this medicine, a pop-up will show that says, what's the pulse
heart rate?
rate?
Yeah. And please, like, if they're on telemetry, please just take an apical heart rate for yourself, please. Those are not always completely accurate.
Especially if it's atrial fibrillation, because it'll pick up QRSs, it'll pick up the T wave like it's a QRS, and that's not. It's inaccurate.
Yeah.
And always use your stethoscope, and where is an apical pulse at? Right side, left side? Left side, fifth intercostal.
Okay, so we all know how to do that. And then because this is so toxic, it's got a narrow therapeutic window. Keep away from children. Keep everything away from children, yes, but especially this one and quinine, by the way. Okay. Oh, we're slow to react. Okay. Other agents that we're going to talk about that treat heart failure. So we have our vasodilators. Okay, they decrease the venous blood, obviously, by blood return, by dilating those veins, right? We have our angiotensin converting enzyme inhibitors. We call them ACE inhibitors. It's just so much easier to say than angiotensin converting enzyme, okay? And that's how they work. They dilate the venules and arterioles, improving renal blood flow and decrease the fluid volume. We have our angiotensin 2 receptor antagonists, which are called ARBs. And these are used when the ACE inhibitors aren't effective or not tolerated, okay? So that's kind of a second line drug to our ACE inhibitors. Our diuretics, which will reduce the fluid volume. We'll talk about those next week. Beta blockers. I told you, you're going to hear these over and over. Beta blockers. Okay. And then there's combination drugs, which will take some of any of these and put them together.
Yeah, it's
to
called
get
a cardiac
maximum effect.
cocktail, which is usually an ACE, it's usually a diuretic, and it's usually a dilator, especially if they've had a heart attack. But just so you know.
Okay, and then you'll find all that information.
And
on
one of the reasons
538.
why you do vasodilators to dilate the blood vessels is to increase oxygen to the heart, especially if it's pain. That's where you get into anti-anginals.
Okay. Here is kind of a visual on how they all work. You've got your vasodilators that work on the arterioles and the veins. You got your ACE inhibitors that work there and the kidney, diuretics. Anyway, another visual on how to get that information.
Now, these are different. Remember today you guys talked about beta 1 and beta 2 drugs for asthma and for COPD and things of this nature. Okay, they do have selective beta 1s. We're talking selective beta 1s, which just do the heart, not respiratory. So you're going to see a different effect. Does that make sense? So there's different ones that work with lungs, different selective ones that work with heart. That's explained in your book very well.
You guys want a break for a minute?
Let's take a break.
Okay, let's take a break.
Grab some candy, go pee, check your Facebook. 5 minutes.
Stand up and stretch.
Online, do you guys have any questions?
Hey, Corby, there's no sound for us at home.
I can hear the echoes of you guys laughing. Is that better? Can you hear now?
Yes.
Okay. Woohoo! All right. So were you able to hear the video?
No, but we can watch it on our own time.
Okay. Yeah. So the link should be underneath in the notes section of the PowerPoint. Okay. So 2 different ways that angina pectoris happens. So first, there's the narrowing or partial occlusion of the coronary arteries, which is what that video showed. Okay. Or you can have a vasospasm. So that's when like the artery, the vessel just like spazzes, right? And it like closes off. Therefore, cutting off the circulation and you have pain. So a lot of anginal attacks can lead to MIs, right? We talked about how the signs and symptoms are described similar to a heart attack. Pain usually lasts only for a few minutes in anginal pectoris. It's not a consistent pain. It comes and goes. And then diagnostic testing is required to determine how much blockage you have in your arteries. Okay, so 3 types of angina. There's the classic angina, which is like a mild occlusion. It occurs with predictable stress or exertion. So at rest, you're fine. If you decide to go out and chop down a tree and haul it away, with that exertion, it's predictable. You're going to know that, if you have this type of angina, you're going to know if I get under any type of stress or exertion, I'm going to start feeling pain, okay? So that's the classic. The unstable is a bigger occlusion, and that can happen pretty much anytime, unrelated to activity, unpredictable, can happen anytime, and it can be a little bit of pain, it can be a lot of pain, so that's why it's unstable. And then we have our variant angina, which is the vasospastic kind. That kind can occur anytime also and at rest, because that's just whenever your vessels spaz up.
And if you don't treat it, it can be fatal. So I think I told you my daughter played volleyball for College of Southern Idaho, won a national championship. Her coach had this spastic arterial spasm. So every time she was having these mini heart attacks, because again, that's oxygen that's not getting to the heart, she ended up dying from it. She died in her sleep. And it's totally stress related. The other thing is, guess when we have the most increase in heart attacks in the ER? There's usually an event and it's coming up. What do you think it is? The first time but you're right, it does. The first time it snows, because people are shoveling snow and they have a heart attack. Yep.
They've done nothing all year until now they have to clean their driveway.
Grab your snowblower, people. Yeah.
Okay, so of course, non-pharmacological measures for angina. So things to avoid: heavy meals, extreme weather changes, strenuous exercise, emotional upset. So keep that stress level down, right? Get proper nutrition, moderate exercise. Now, this is not strenuous exercise. This is just little moderate to help, work out your heart, have your heart get stronger. Adequate rest and relaxation techniques. Now, a combination of non-pharmacologic and pharmacologic are usually needed and used in combination. Okay, so drugs to help your angina. We have your nitrates, your beta blockers, and then calcium channel blockers. Those are kind of new to us. Nitrates are new too. But so anginal drugs increase blood flow to the myocardium by 2 different ways. It either increases the oxygen supply to the myocardium or decreases the oxygen demand. Okay?
That's that preload and that afterload. That's where that comes in.
Okay, so nitrates, we're talking about nitroglycerin. Comes in a couple different brand forms, but you always have nitro in there. So action, it promotes vasodilation, decreases the preload and the afterload. Okay. Side effects, if it vasodilates, what kind of side effects are we going to get? Decreased blood pressure, right? Because you're vasodilating.
And you usually make this mistake once. People will give nitroglycerin in the field, but EMS people, before they have an IV established and they haven't taken the blood pressure and they bottom out their pressure. And it's like, oh shit. The other thing is, where are some other blood vessels in your body that would be affected by vasodilation? This is the whole body.
In the brain. So that's
what do you
where you
think is
get
going to happen if it dilates in your brain? It increases your
ICP, yes.
Increases your
We're going to talk about that, yeah.
which then gives you a headache. Number one thing, number one side effect. And it happens quickly, especially if you put it under the tongue, sublingual.
And it's really, really good. So this is going to vasodilate better than anything.
It's the first thing. If you came in with chest pain, we would give you a nitroglycerin if your pressure was, above 110 systolically. And then if it didn't resolve in 5 minutes, we would give you another one so long as your blood pressure supported it. And we would give you another one. If after 3 times, 3 nitroglycerin does not work, then we get more aggressive. Okay, that's when we add opioids.
It's got all morphine, really, right? Yeah, morphine.
There's
okay.
Morphine.
Anyway,
Mona. Have you heard that before?
All sorts of.
Oh, you're gonna hear that.
It's got all sorts of routes of administration. Sublingual is going to be the most common. We've got topical, aerosol spray, inhalation. You can give an IV. You've got buccal, oral extended release capsules and tablets.
And what did you do in PN1 when your med pass off? You did patches, right? There was a little squirty thing. And
For the love, do not touch these with your bare hands. Any.
Why do you think that is?
Any patch.
Exactly. It goes through your hands.
You
and then
will
guess what? You
absorb
get
it.
a massive headache because you touched the nitroglycerin. Okay?
It's strong stuff. It's strong stuff. Okay. So some people do use this as a rescue med, right? When they have their anginal episodes, but some people do use it continuously as well. So if you are using it continuously, do not abruptly discontinue this. It'll be bad. And then don't give with other vasodilators. Sildenafil. Who knows what that is?
Oh,
it's a vasodilator.
It revolutionized men's health.
Yes, it's Viagra. So Viagra is a really good vasodilator too, which is how it works. Anyway, we won't get into that, but those two together equal death.
Okay, so remember how I told
Big
you
problem.
that you study because you might be the only person between the patient and death. So this is where medication reconciliation comes in. Had a patient come in and had chest pain. And so I said, what medications are you on? And he said Viagra, okay? And the physician had ordered nitroglycerin as part of a chest pain protocol. What would you as the nurse do?
Question the order.
Yeah, you better go back.
Tell the doctor, yo.
Yeah. Okay, a lot of times these doctors put in meds and they don't know the patient's history yet, or it's just part of the chest pain protocol because we're a certified center, so we've got to do things quickly. Okay, this is the reason to know, okay, what the nitrite does and what this interaction. So they were trying the Viagra then when they were developing it for chest pain, and it had this side effect. And it's like, oh, and guess what? Revolutionized men's health.
So you do have to be careful. Think about it though. Like if you have an older male that comes in with chest pain, there's a chance that maybe he took some Viagra to have a fun time with his wife or partner.
Takes it as needed. So guess
And
what the first question is I ask? No.
History.
I asked, do you take Viagra?
Oh, okay.
this is huge. I mean,
It's
you don't
huge.
want to take with other vasodilators, but this sildenafil, the Viagra, is like named specifically
I
for
just
this drug.
assume. You just assume unless otherwise noted.
So,
Should I rely about that?
All the time. All the time.
Okay.
yeah.
Except when they come in with an
But
erectile, an erection that's lasted more than 4 hours, and yeah, then it gets
So do you
really.
explain that to him? You really have to tell me these
Yes,
things.
exactly,
Yeah.
exactly.
Yeah.
And this is the reason why your CAM reports are so crucial, because people will say, I ask them, do you have any medical history? No, I'm good. Okay, are you taking any medications? Yes, I take nitroglycerin, and I take Synthroid, which is, for thyroid. I take, high blood pressure medicine. I'm like, okay, so do you have high blood pressure? Well, it's controlled. I take medication. So they don't think they have this condition. You
Because
have
it's
to be
controlled.
smarter.
Yeah.
You
yeah.
have to be smarter.
Okay, so you can see here, these sublingual tablets, they come in like a little amber bottle with a screw top. They have to stay in the amber bottle. Don't put them in a prescription bottle. And because the light will deactivate it. Okay, so they're in these amber bottles, and they should not be in a child-resistant bottle. Why? Why do you think they should? When I worked at the pharmacy, we had to we could not put them in a child-resistant bottle. Because they got to be easy to open. If you have intense chest pain, do you think you're going to be able to open that bottle very effectively? No. No, if you can screw it off and pop yourself a pill, that's so much better than trying to figure out these child safety caps, right? So they have to stay in that bottle. Anyway, so very, very, very important to keep this medication away from kids. Out of reach, because they're not in a safety, they can't be in a child safety thing. It comes in this ointment that actually you measure. Like, it's kind of interesting.
That's
Measuring ointments
pass-offs.
and stuff. But you measure that out so that you know exactly how much you're doing, and you rub it on. Transdermal patch, we talked about that. Do not, for the love, do not touch. And then you have all these other ones that aren't necessarily used quite as much, and you won't be dealing with the IV stuff. Yeah. Okay, here is our drug stuff. There's your Viagra, and then your other vasodilators. Antihypertensives, you want to be careful with that, because what do? Not necessarily dilate. They can work in other ways, but antihypertensives are going to do what? Decrease blood pressure. So if you're taking nitroglycerin on top of that and vasodilating, your blood pressure is going to go even lower. So very important. These are beta blockers. These
And why would you not take
calcium
alcohol?
channel blockers?
Okay, it's depressant, but what does it do? Have you ever seen people when they're drunk, their face is red?
Oh, it's a
Flushing.
It's vasodilator.
yeah.
Yep, it's vasodilator.
Which is why you get the flushing in the.
Because it's more.
They say don't drink before doing a tattoo.
That would make sense.
Because they're not to drink alcohol.
Well, that's maybe because so that you would, not put a stupid tattoo somewhere. And liquid courage, It's like, oh yeah.
Liquid courage. Okay, so be careful. Don't DC it abruptly if it's used continuously. Now, transdermal patches are over here, right here. It says to take off at night. This medication is actually, you can develop a tolerance to it. So that's why they take it off at night, so your body has a break from it, so your tolerance isn't built up quite as fast. Okay, you can take acetaminophen for headaches to help with that headache, right? Because it can get pretty intense. And then, Mark, there's your contraindications is the head trauma. Because of the increased ICP that you can get with a head trauma, you give nitro on top of that, it's going to make it worse. You'll have this spiral effect. It'll be bad. Don't do it. Any questions on this?
Does it make sense?
Nitro's great. Okay, other notes. Sit down or lay down when administering. Not you as a nurse.
Yeah.
Have the
That
patient.
would be hilarious. I'm laying down. Here's your medication.
Have the
That's
patient
awesome.
sit down. It works really fast. I think I thought I had it in here. The half-life is less than like 5 minutes.
Yeah. Especially sublingual.
Like it's crazy
It's
fast,
quick.
happens really fast, okay?
In fact, within 2 minutes, you don't need to know this for the test, but within 2 minutes, you'll see a decrease in the blood pressure. So when I give nitro, I'm recycling blood pressure in 2 minutes. And you'll see it come down.
Don't apply patches in the vicinity of defibrillator placements. You can burn them. Call the doctor with signs and symptoms of severe hypotension. Keep hydrated. Call 911. If we're dehydrated, what does that do to our blood pressure? Decrease our blood pressure. Okay, we understand why we need to keep hydrated.
The water helps activate
Oh,
the
yeah.
drug because your saliva
In your mouth,
helps.
yes.
So if you're dehydrated, you're not going to have a lot.
So give sips of water before you give the tablet. Okay. Call 911 if angina isn't better in 5 minutes, or you've already given 3 doses of nitro and it's not getting better.
And that's what they say. You know, people have this at home and they're, you know, shoveling their snow and they're like, ooh. So they sit down and they pop a nitro. 5 minutes later, they'll pop another one. 5 minutes later, they'll pop another one. Hopefully, they've taken their blood pressure before all of this, but not necessarily. And if it doesn't stop, then they're instructed to call 911 and get in. Because then it's gone from stable to what? Unstable.
And you could actually have a complete blockage, so they could actually be in an MI because of their angina. And we want to get that treated as soon as possible. And then once again, don't apply ointment or patches with bare hands. It's bad. Okay, on to beta blockers. Any questions about nitro? Beta blockers, these are our friends, right? We've heard about them a lot. Okay, so they block the beta 1, beta 2, right? They block the action of the catecholamines, which is the epinephrine and the norepi of our sympathetic nervous system. Okay, this should all be review. If it's not, maybe you should go back and study chapters 15 and 16, I think.
Yeah.
Anyway.
That's so long ago.
I know. But remember how we talked about how everything builds on those 2 units?
Yeah. It
this
absolutely
is
does.
an example of it.
Okay. So it decreases the workload of the heart and decreases the oxygen demands. So that's how it's going to help with the angina. Okay. Side effects are adrenergic antagonist side effects. You get the bradycardia, hypotension, dizziness, depression, fatigue. You can get some sexual dysfunction, peripheral edema, bronchospasms. Okay, that's the beta 2, right? And then we talked about this before, don't abruptly discontinue these beta blockers.
No bueno.
Not a good idea. Who remembers why?
And it talks about why in your book, okay? Remember how we talked about dexamethasone as these corticosteroids and how they have to be tapered because if not, you get rebound. Same scenario here.
Okay, so these are multi-use medications. You can use them in heart failure, angina, dysrhythmias, hypertension. Okay, propranolol is a non-selective beta blocker. What does that mean? Effect, right.
Yeah.
Good job, Mark. It's not specific.
And that's the reason why propranolol has other uses. Okay, they'll do it in hypertension, and they will also do it in migraines. That's important to know.
Propranolol for migraines is great for a lot of people. Okay, so propranolol non-selective, so it affects beta 1 and beta 2. So you'll get the heart benefits, but then it'll affect your lungs too, right? Okay, so you want to be careful with those, giving propranolol for any of these things with people with what kind of conditions? Let me rephrase that. You want to be careful giving propranolol for any of these conditions with patients with what other conditions?
Yes, that's true. That is true.
Good.
And why is that true?
Because glaucoma already has pressure in the eye. So it increases pressure.
Yes.
Yes, the pressure in the eye. What other ones? COPD, and then there's one more. Asthma. Okay. Because that affects the lungs, right? And we're affecting the lungs and blocking the albuterol if we do that. Okay. Atenolol and metoprolol are selective beta blockers. They only affect the beta 1. So they're not going to do beta 2 unless it's in really high doses. So they're selective. They're only going to affect beta 1, which is going to help us with all of these conditions and not affect our lungs. Okay, so you'll want to know that, which one's selective, which ones are selective, which one is non-selective.
So this is increasing the oxygen supply when we're talking, oh wait, that was angina drug. Yeah. So is this increasing the oxygen supply? Is that?
Or decreasing the demand.
So both.
So, it's doing both?
Yeah. Well, think about it. If it dilates the blood vessel, okay, it lowers the blood pressure, but it also allows more blood to get to the heart, arteries, which is going to be delivering more oxygen. So it's decreasing the demand that the heart needs to function.
Okay.
Does that make sense?
Yeah.
Okay. Maybe I showed this the first time we talked about beta blockers. But here's a little visual. They end in the lull. Yada yada. Decrease the heart rate, force contraction.
Most drugs have a last name. This is beta blocker's last name. OLOL. Mm-hmm. Okay. And I'll put up a little visual of drug last names in the study helps. Okay, it's just a little picture.
You'll see them in the ARBs.
Yeah.
The sartans, the
losartans,
statins,
the prams, the prils, things like that. Those are the last names of the drugs, and you're going to see them. Now, here's the thing. I'm going to get to your question. So I know we're all doing like drug 3x5 cards. Okay, if you've ever had me as a nurse, okay, and I say to you, okay, what does this drug do? Because we're going to go give it to this patient, and you're like, I don't know. Let's see. I might be able to look it up on the computer. Okay, if you've done your concept maps, okay, if you've done your 3x5 cards, you know what that drug does. So keep a list. Okay, when you go to clinicals, keep a list. Oh yeah, I've done that. Okay, yeah, this is I'm giving it for chest pain. Blah blah blah, whatever. So be smart with your assignments. Okay, make the connections as to why we're asking you to do this, which is not busy work. Okay, all right, your question.
It might be in the book, but I was
okay.
When would you use propranolol over Entyl? Like I don't see
the atenolol.
Yeah, whatever. So why would you use that over? When would you use that over Entyl?
Honestly, it depends on the patient, the doctor, and the situation.
Yeah. That's out of your scope of practice. Don't worry about that.
Yeah.
But again,
because everybody's different. Their symptoms.
There's lots of off-limit
degree of
off uses for propranolol.
Yeah, their degree of disease is different.
Yeah.
Doctors might prefer one med over another because of maybe what he's seen in practice. I don't know. It all just depends. But these are medications that help it. Okay, calcium channel blockers, usually abbreviated CCB. You'll see that, calcium channel blockers. So what do you think these drugs do? Block the calcium. Right? Because all our contractility and all of our heart and the electrical stuff in our cells, we do potassium, sodium, calcium, right? That goes in and out of the cells
and especially in the heart, and you'll see it because that's part of the action potential, right?
Which we'll talk about here in a minute.
And so that's when sodium rushes in, and then when calcium rushes in, and then when potassium rushes in. So this goes to the conduction area. This is the electrical thing. If they're trying to block those things to help the heart conduct a little better, which then will help the heart pump a little better.
Right. So what calcium does is it activates the myocardial contraction.
Santa's here.
Okay, so the calcium activates the myocardial contraction, which increases the workload of the heart and the need for more oxygen. So that's what calcium does. So if we're blocking this, we're going to decrease the workload of the heart and decrease the need for more oxygen. Okay. And so these ones work well for the vasospastic type because it relaxes the spasms, the electrical impulse. It helps relax those. So the spasm and the need to contract is relaxed. So that is real. These are really good for vasospastic type and the classic. These also are used for dysrhythmias, which we'll talk about them again, and good old hypertension, which we'll talk about next week. So the drugs here are verapamil, nifedipine, and diltiazem. I think diltiazem is number 1.
Yeah, diltiazem is number 1. And this is my story, another story of between you study, because you are the only one. You'll have a day when it's between you, the patient, and the grave, okay? So diltiazem is also used to kind of help convert out of rapid AFib, okay? And if you look at your drugs, it's and amiodarone is the other one. And amiodarone has a push of 10 minutes, okay? And this is what we give in ACLS after a person we were able to get a heart rhythm back from VFib or VTAC if we have to shock them. And then we push amiodarone, which again slows down this rate, slows down and gets it into normal rhythm. And the nurse was, and you have this thing called closed loop communication. You got to say what you're doing because it's a code situation, okay? All heck is breaking loose. And so he says, I'm going to give amiodarone 150 milligrams IV push. And I was like, no.
Slow motion.
Okay. I didn't say that. What I said was, WTF are you doing? You know, I'm like, no, it's a 10-minute push. Had 10 mLs. How many mLs per minute are we giving? 1. That's a long time. If he had pushed it, she would have died. Okay, because you can kill somebody with beta blockers. You can kill somebody with calcium channel. So that, again, you gotta know your drug in those situations. That's what we're helping you. You don't have to be perfect here, but you gotta know your drugs. What do they do? Okay, saved your life. I don't know if that was good. She's a drug dealer, but anyway.
Okay, it's a little morbid. Okay. So, like we talked about, the calcium channel blockers relax the coronary artery spasm, okay? Decreases the contractility, afterload, and peripheral resistance are all decreased, okay? Reduces the cardiac workload and oxygen demand, like we said before. As with all drugs, they all have side effects. Here's your side effects. Dizziness, flushing, headaches, hypotension, reflux, tachycardia. Did I say reflux? I meant reflex. Peripheral edema and fatigue. And here's one of those things for this. These, you can think of very nice drugs as the 3 main drugs in this category. For verapamil, nifedipine, and diltiazem. So there's...
And nifedipine on an IV we use to decrease blood pressure. And we'll do it on stroke.
Okay. I know this picture is crazy blurry. I could not get it to not be blurry. However, it's in your book. Non-blurry in your book on page 543.
So
this
there.
Basically just goes through the steps on what you're going to do to treat this angina. So usually you start with nitrates.
What's a nitrate? Give me an example of a med. Nitrate. Vasodilates. Okay, but what's the name of it? Nitroglycerin.
Nitroglycerin, right.
Yep.
Nitrodur. Nitrodur, yeah. Then let's say that works for a little bit, but then it doesn't. Then we're going to add the beta blockers on top. Then when that doesn't seem to work quite as well, we throw the calcium channel blockers on top. And then if that doesn't work, what do we do?
They go to the cath lab. There's something wrong in there.
They've got to have a bypass. Okay. So we're starting with the least invasive, going until we don't have any more choices and we have to cut them open in some way, whether it be open heart or cath through the artery.
Mm-hmm. And they're actually now going through the wrist. They used to go through the femoral artery. Now they go through the wrist.
That's so crazy.
I know. This is the thing, people. It changes so fast. So one of the things you guys have to be able to be open to change. And this is your responsibility to kind of keep up on what's going on. Not right now. Your responsibility is to get it in your head.
So that's the classic angina. Variant angina See how beta blockers are left out? The variant angina.
Because they're not effective.
That's the vasospasms,
They're
right?
not effective. That's in your book. There's a little chart that says what's effective for which of those 3 disorders.
So we do our nitrates, calcium channel blockers, and then we do our bypass. Good time. Here's another one. It does kind of the same thing as the one before. Kind of tells you what the meds are, what they do, if they're effective or not on the different types. So another way to look at that. And here we go again. Another way to look at that. Some of you are graph, like,
visual learners.
papers.
Your visual learners, this is going to speak to you. Okay?
Yeah,
because
you can
visually,
look at
how
the
does
heart.
this work? The chart is for your reading and writing. Okay? And if you're kinesthetic, I don't know. You're going to have to make some, some other.
I was trying to get to all of you. Different
Yeah.
charts. You can take whatever one works for you and run with it. Okay. Cardiac dysrhythmias.
Let's hurry because I got to leave at 10:15 or 12:15.
Okay, we'll go to 12:15 and then maybe take lunch if we're not done by then.
Just because I'm going to have to peel off. Okay. Is this helpful in terms of how we're doing this? Okay.
All right. Cardiac
And
dysrhythmias.
it's helpful for us because we can see your eyes and we can see when you get it and when you don't. So encourage
Absolutely.
everybody that's online. We know you're online, but try and be here. Okay. If you're at all able to.
Okay, so a dysrhythmia is any deviation from a normal rate or pattern of a heartbeat.
What does dys stand for? Yeah, abnormal. Abnormal.
Abnormal.
Not
So we
normal.
have an abnormal. It's not normal. So there are many, many different kinds, but here's just a few. We've got our typical bradycardia, our tachycardia, our irregulars, and then you have like irregular heartbeats. Then you have your irregular heartbeats. Then you have all the other ones, right? The V-tach, asystole, yada, 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 yada. All those different types. So SVTs, the supraventricular tachycardia.
And that means super means on top of, ventricular is the ventricle, tachycardia means fast. So instead of the beat that's coming from the SA node, it's coming from the ventricles. And it's a re-entry. And so it's fast.
That was from somewhere in the atria.
That's atrial tachycardia. Super means on top of, ventricular.
So on top of the ventricle.
It's on top of the ventricle. Yeah, it's on top of the ventricle.
Yeah.
Did you learn it differently? What did she say?
Supraventricular. Ventricular, it means it's coming from somewhere in the atria. It's not ventricular. Where's my paper?
I'll check. That's fine. If that's what she said, I'll check it out.
So your book doesn't go into that type of stuff. We're just covering dysrhythmia. So as far as this class goes, any deviation from a normal heart rate, that is what we're treating, okay? Diagnosed by an ECG. And then like I said before, despite the different meanings, dysrhythmia, arrhythmia are used interchangeably. All right.
There it is.
Here's our action potential. You guys will need to know this and what happens in each phase. Okay. So here we have phase 0. That's when sodium rushes into the cells. Okay, sodium channels open. Sodium rushes into the cells. It's getting ready to contract. Okay.
This should be review for you.
Is this review?
Yeah, this should be review. This is
No?
from your
Yeah.
anatomy. This is from biomed.
Oh, the action potential.
This is the action potential. This is
Okay.
review. But the important thing is to look at what comes in. So sodium comes in, then calcium comes in, then potassium comes in. So when you talk about channel blockers, calcium channel blockers, then you know kind of which phase you're talking in because it relates to the electrical QRS of it.
Okay, yeah, so phase 0, you get the sodium coming in. Phase 1, the sodium stops, and you have your contraction, right? Phase 2, that's where the calcium comes in to prolong that contraction. And And then phase 3, that's when the potassium comes in. It doesn't say it here because that says sodium, calcium. It doesn't say potassium here, but I promise that's where it happens. So in your book, you can write it. That's what I did. You can write potassium influx right here. And then 4 is when everything stops, it can rest to get ready to do it all over again. Okay?
60 to 100 times a minute.
Okay, so here is this. This should all be review as well, right? You've got your P, Q, R, S, T waves, what the PR means, what the QT means, what the T means. You guys can all review that. I won't necessarily get into that.
That's what you did the last couple days, right? Yesterday.
Perfect. Okay. So maybe that'll help.
Okay, so these are some fatal heart rhythms. This is one of the things.
What's that one?
Yeah. It's also known as asystole. This is also a fatal heart rhythm. But it looks pretty good, doesn't it?
It looks like it's a regular rhythm.
You betcha
it does.
And this is a fatal heart rhythm because this is called pulseless electrical activity, PEA. This is where the pump does not work, has no pulse, but the electrical conductivity of the heart still is contracting. Does that make sense? So
your electrical is still going, but your heart is like,
but your heart's not. No
still
pulse.
just sitting there, not doing anything. Which is another reason why you don't want to just look at the telemetry.
Yeah, always look at your patient.
They're good, yes, but always look at your patient. Yeah. Monitors are good when they're good, but they're not always accurate. You look at the patient. Okay. So, cardiac dysrhythmias often begin with an abnormal, unexpected impulse somewhere in the myocardium, but not from the SA node. So it's coming from the AV node, it's coming from the bundle of His, it's coming somewhere else.
Or on top, in the ventricle, in the atrium.
Somewhere. There's another something that wants to be in charge, and it just can't. The SA node needs to be in charge. Okay? Often caused by problems with the electrical conduction, like we said. Most have a negative effect on how the heart works, right? Does that make sense? Dysrhythmias are usually often always bad.
Often always. You can live with it. As we age, the SA node doesn't work quite as well. That's the reason why so many older people develop atrial fibrillation. Because it's not working.
Our body does compensate for it. Yeah. Like, that's why we get into heart failure and stuff. Because
and the heart
can compensate for a while.
The heart fibers have the ability to conduct their own beat. That would have been from anatomy.
I don't think I have on this. I was looking at a million videos yesterday for you guys. But so the heart has its own conduction system. You guys all know that. So it will pump out of your body. Did you know that? Like if they take your heart out of your body and set it down, it will still pump because of the electrical impulse. It does its own. Anyway,
it has its own system. I know, heart's amazing. So if you love this, if you're a heart person, I'm just gonna eat it up.
Okay. So decreased cardiac output has often resulted in these dysrhythmias. Okay, and if you remember, it's cardiac output is the amount of blood the heart pumps out in a minute. And then you'll get these symptoms with dysrhythmias, if they're bad enough. Fluttery feeling in the chest. That's not butterflies because you saw your crush walk down the hall. Lightheadedness, racing heartbeats, palpitations, not to be confused by palpations. Palpitations, right? Dizziness, because you're not getting enough cardiac output. Fainting, slow heartbeats. You can get the racing heartbeats too. Or sometimes people go in between. Chest pain, shortness of breath. All of these good, fantastic things. Okay, risk factors for dysrhythmias. Older age, just like she was saying, our SA node just
wears out.
Isn't what it used to be. Had better days. Genetics and family history. You
can't run out your genes. Can't run away from your genes.
Disease processes, including diabetes, hypertension, coronary artery disease, and obesity. Thyroid problems. You're going to get a rapid heart rate with hypothyroid, slow heart rate with hypothyroid. Obstructive sleep apnea. That's just bad. All the way around with everything.
Most people that have atrial fib have sleep apnea. Those people do.
Okay, so if you or your partner think that you have sleep apnea, get that figured out because it's just bad with all sorts of your whole body system. Okay, electrolyte imbalances, right? Because we're talking about the sodium, potassium, calcium. If you're imbalanced in any of those, it's going to affect the conductivity of your heart. Drugs will affect it. Your pseudoephedrine, right? Caffeine.
Yeah.
I think I saw enough caffeine in that garbage can.
Yeah. Your monsters, okay? Another
to kill
story.
Someone.
Had a kid your ages, younger. You guys are young. Come in and he's like, "Oh, my heart! It just hurts." We put him on a monitor. His heart rate was 210. Okay, and this dude drinks Monster like no other, and it threw him into an SVT. We had to cardiovert him, and guess what? It had damaged his heart. He had, because when your heart rate is going that fast, it's not getting oxygen to the heart. Okay, he had had a heart attack. This kid was 19 years old.
Be careful with your energy drinks, people. Please. If you don't die of a heart attack, you'll die of an aneurysm.
Yeah.
One or the other.
Because he drank Monster, and then he would do,
Then you're, you got your typical alcohol,
Are we
cocaine,
okay back
amphetamines.
there? Are you guys okay back there? We're doing okay? Questions?
Okay, and then like I said before, all antidysrhythmic drugs have the potential to produce new dysrhythmias. This means they are pro-arrhythmic. So if you're giving a drug to somebody who has a certain type of dysrhythmia and you look at their telemetry and you're like, oh, that's new. That's a new rhythm.
It's a problem.
It's a problem. You'll need to call the doctor.
Get your charge nurse too. That helps.
Yeah. Okay. So different types of anti-dysrhythmic drugs. We've got, they're in 4 classes. We have our sodium channel blockers. You can guess what they do. Look, there's our beta blockers again. Potassium channel blockers. They are not called potassium channel blockers in your book, though. They're just group 3 drugs that prolong repolarization. But they work on the potassium channels. And then your calcium channel blockers. So the sodium channel blockers have subclasses, 1A, 1B, and 1C. We're only going to focus on the 1B, though. Try to make it easier for you. Okay, so here's atropine. Atropine is... Oh yeah, it's 12:16. Let's stop right there.
Can we go to adenosine? Because
Yeah.
I have to peel off for the rest of the day. So let's
see, where did we put it?
Because you'll come back to it. So we use adenosine a lot.
There we go.
Right here. So here's the adenosine. We use it for PSVT, okay? And it is a chemical way to restart the heart. It stops the heart, kind of like rebooting your computer. We're rebooting the heart chemically, not physically shocking it, but chemically. And so you'll be, obviously the patient has to be lying down, but the patient feels like crap because guess what? The heart is at a standstill. The very next one should be Milo. Okay, that's what you see on an EKG. Okay, so you can see that fast heart rate on the left. See how it stops. You get a couple of ventricle things. And then look on the far right. It starts beating properly. And there's a video that, has, I think you got a video in terms of someone getting adenosine. All right, because it has a very, very short half-life, like 5 seconds, 5 or 10 seconds. So you got to get it to the heart quick. So that's how. Any other questions that I can answer here?
What class is this medication under?
How this is an antidysrhythmic.
Why do you use for SVT?
It's SVT, and that's all that we're talking about is tachycardia drugs.
This is under class 3.
So,
This is a class 3.
okay. So potassium channel blocker, not
Yeah.
class 3?
So on a side note, people that get lethal injections, that we kill when they're in prison, guess what we inject? Potassium.
And pigments.
Yes, so that they don't feel it.
Yes.
But yeah, potassium, because too much potassium will kill the heart. And so that's what this is what we're doing, chemically trying to restart the heart.
That does happen.
We're good? You guys are awesome? Okay, come see my door. Let me know what you think of my door.
I need to come see your door. Okay. Let's go back. Did you guys want to do lunch right now? Yeah? Okay, we can do lunch.
There's always a chance for something, but there's no bringing back someone who's done. Very true.
Yeah, there's not much. And then I have cahoots at the end.
Get to do cahoots.
Okay, let's do lunch. We'll come back at 1:45 and finish up.
How many slides do we have left?
Well, that's a good question.
15. 60.
She's
done
40.
We're 48.
Just less than
There's only 3 slides. Let's just hurry and do them. Now we're understanding.
Oh, yeah, we jumped. Okay, so let's do lunch real quick, fast 30 minutes. There we go. Perfect, thank you. Appreciate it. Okay. Okay, so we kind of went through that. The sodium channel blockers have 3 subclasses, but we're only going to talk about the 1B. Okay, our beta blockers, which are good for multiple things. The potassium channel blockers are drugs that prolong repolarization, and then our calcium channel blockers. I'm just going to open the book, just Okay.
No, whenever.
Do we need to start the Heimlich? Just let us know.
Yeah.
Bang.
The abdominal thrust now.
Bang on your desk for the Heimlich. Okay. So I want you guys, so these drugs real quick are for tachydysrhythmias. You see that? I want you guys to be aware of this one, atropine. We've already talked about it. It's our adrenergic antagonist, right? Okay. So adrenergic.
No.
And yes, anticholinergic. There we go. I just had to keep reading. Okay. So this guy is really good for dilating pupils, right? Also really, really good for bradydysrhythmia. So any type of bradycardia, right? So it's used in symptomatic bradycardia. If you're involved in a code, you're going to see this in the code cart. What do they call that?
Crash cart.
Crash cart. I don't know why I couldn't think of that. So this is going to stop the heart from being slow. It's going to speed up the heart. I was involved in a code this last spring that was really bad. Anyway, and they waited and waited to give atropine, and they should have given it sooner, if you ask me. Anyway, so you'll see this in the code, the crash cart. Now this is for bradycardia. Okay, and then we already talked about digoxin for atrial fibrillation. That's a tachycardic dysrhythmia, right? So you can read through that. We already talked about it. Okay, so our class 1 sodium channel blockers. Like I said, the 3 subclasses are the A1A, 1A, 1B, and 1C. They inhibit the sodium from moving into the cell membranes, okay? It causes a slowing of the heart rate, reducing the cell excitability, and reducing the speed of conduction. So it's just going to chill out the heart. You want the heart to chill out, okay? It inhibits the ventricle's ability to contract prematurely. So you're not going to get any of the ventricle contractions on top of the atrial contractions. It's going to chill it out so it doesn't contract quite as fast. Okay, and the drug we're going to talk about is lidocaine. What is lidocaine also used for? An anesthetic. That's right. So this is systemic lidocaine. The anesthetic is going to be direct acting. That's where you get either the injections that are direct acting or the topicals, right, for the anesthetic. This is IV. And I understand you guys don't do IVs, but you still need to know about the drug, okay? Treats VTAC, symptomatic PVCs, and prevents VFib. This drug acts really fast. It is short-lived, and given IV, only a third of the drug reaches what it's supposed to do. It gets broken down really fast. So a lot of you might see, if you're in the ICU or the ER, you might see lidocaine drips because it is such a fast action. It gets broken down really fast. But lidocaine has a lot of serious adverse effects, especially if it gets into toxicity levels. Okay, so here we go. Inhibits the sodium influx. It treats life-threatening dysrhythmias. Most commonly used as a local anesthetic. Adverse effects: it can cause bradycardia, hypotension, dizziness, restlessness, confusion, vision changes. You get metallic taste in your mouth, and toxic levels can cause seizures. Contraindications: a lot of these with AV blocks and cardiogenic shocks, you're not going to want to give a lot of these meds, like in the class 1, class 2, or class 3, or class 4. Alcohol, caffeine, tobacco, and then watch out for adverse effects. Okay, now back to our beta blockers again. Yes?
Do we need to know the toxic level of lidocaine, or just know that it can become toxic?
It can become toxic. Really the only drug level you might be tested on is digoxin. Okay. Did I mention that's above 2.0? Okay, all right.
Thank you.
Yep. Okay, so it blocks the effects of epinephrine in the heart, right? It's your adrenergic antagonist, right? I have to read it in my head as it scrolls across. It's so weird. Okay. It decreases the heart rate, slows down the heart and the force of the heart contractions. Okay. It also decreases the blood pressure, which one reason why it can be used as an antihypertensive as well. And then you have your cardioselective beta blockers. This one, you can call it acebutolol or acebutolol. However, people, as you know, with angina and angina, pronounce it differently. So this, let's see, is a non-selective beta blocker, and they all have systemic effects.
Question.
Yeah.
So can you use the beta blockers that you listed for angina? Can you use those for can you cross-use them? Does that make sense? We're talking about beta blockers again. Is this still going to be in the same classification as propranolol and atenolol, or are we separating them because they only work for those diseases?
Let's see. So as far as antidysrhythmics, propranolol is pretty much like a umbrella, but it's non-selective, so you gotta be careful with that. For these dysrhythmics, you're gonna be looking at the acebutolol.
Okay, so try to separate them.
Yeah. Yep. Okay, here we go. Your beta 1 adrenergic antagonist. This can also treat stable angina and hypertension, but it's not usually used. You're going to go with a other different types, but it is a beta blocker. They all just kind of work. They're all different, or it'd all be the same drug, right? If they all did the exact same thing, it'd all just be the same drug. So they're all a little bit different. So one might work a little better with dysrhythmias, one might work a little better with angina, but they're all beta blockers. I know it's a little confusing. Sorry, let me go back. Okay. Blocks the effect of albuterol, so you gotta be careful with the asthma and COPDs, right? It's the beta blocker. I feel like this is repeat because of the beta blocker stuff. Any questions? Okay. All right, class 3. So drugs that prolong repolarization. These are your potassium channel blockers. Based on evidence-based practice, all of this is. So it blocks the potassium channels and slows the outward movement of the potassium. So it prolongs the repolarization. So it, the repolarization is the relaxing of the muscle, right? So it's contracted, now it's relaxing. It prolongs that relax, so it slows the heart down that way. We talked about amiodarone, right? Is that what? Remind me, is that what Debbie went over? No, she went over adenosine. Yeah, okay. They'll start with A's. I'm getting confused. Okay, so this one, as always, has a high risk of inducing other dysrhythmias because it affects the the electric pulses in the heart. It can cause other dysrhythmias too. So can be given IV or PO, is associated with serious side and adverse effects, and numerous drug interactions. Guys, just take care of your heart. Don't let it get sick, or you're going to be bouncing around. Who sees our friend up there?
Grapefruit.
Grapefruit! Don't take grapefruit with this. So I won't drink it. I won't eat it. Okay, so amiodarone can also cause photosensitivity. So you'll want to keep track of that. Maybe, and then blue coloration of the face, neck, and arms. Believe it or not, like look at all these adverse effects. You don't necessarily want to take amiodarone if you don't have to. So, exactly, yeah. Okay, adenosine, this is what Debbie went over. So here you have your PSVTs. You'll see this in crash carts too. No limit to the number of doses. Patient has to be lying down because they go into asystole. Asystole occurs before the sinus rhythm. So if you are in the ER and I recognize you won't be the ones giving this, but say you're involved with this code, right? And you have the patient on the gurney and you have your family next to them, you know, obviously freaking out because something's happening to their family member, and they're going to give this medication. What would maybe be a good thing to let the family know? Exactly. The monitor is going to go flat. They know, they've seen enough medical shows and Grey's Anatomy to know that asystole means death, right? So when they see that monitor go flat, even for a few seconds, trust me, they will freak out. So letting them know beforehand and say, hey, we're going to give this med, you will see their heart rate stop. That's normal. That's what we want. We want it to stop because it's resetting itself so that it can start up again and beat appropriately. Okay. We talked about that. There's your, and the asystole, just so you know, like this seems pretty short, but it can last up to like 10 seconds, 15 seconds sometimes, depending. So it might just be a tiny little blip like on there, or it could be elongated and scare the crap out of your patient's family. Okay, so let me try. Yeah, people are on there. Okay. We're going to start back here. This is a lady that's getting adenosine.
And you've actually had multiple current episodes of the FBC. I'm going to go right up on the screen here and yeah, feel heart rate 170. Back over here and we'll look at it.
So this is going to be given anything heart rate above 150.
Pretty fast. So, first of all, you're okay being on YouTube, being on a video and all that. Like, okay, good.
She's a sweet lady. I wish she was my neighbor.
Usually you respond to the event. And
increase the volume.
Okay. I want we did get as the
yeah.
I'm just stealing this. I'm so sorry. I just really want to say hi.
Other people who
Love you guys.
experience the same thing.
I just want to like sit here and absorb your energy a second. Smell the food.
Okay, good.
You don't want our energy, honey.
Have you ever had cardiologist evaluate you? Okay. Have you ever had any diagnostic studies of your heart other than EKGs? No. And you were on a beta blocker, metoprolol, at one time, and then that got discontinued. When was the last episode that you had?
Is this an actor?
No, this is real.
2 months ago. Okay. You went home without any different medications. What's that? Yes, same medications. Okay. What medications are you on? Okay, so you had your thyroid removed. So we're going to check a thyroid level on you to make sure you're not too high on your thyroid. And what else are you on? Calcium. And that's it. Okay, you're not on any medications to prevent you from having fast heart disease. Okay. All right, good enough. All right, we'll stop right now on this. We will, once the action starts, we'll start it back up.
Okay, so he's using a stopcock, which is what is going to have to be used.
So Chris, can you tell us what you're doing? So you put together a little stopcock here. And then we have to get it rapid approach. The one side here is the adenosine, 6 milligrams. The other side here is saline. So you do the adenosine, you put the switch, you put the saline right back.
And they'll have to do it as fast as you can.
You decided to say something to both you, Chris. You don't mind being on video. Okay.
I think it's awesome. He's getting their permission as he's filming.
Yeah.
So it unfortunately doesn't show her telemetry when he does it, which makes me sad, but you can at least see how she reacts to it.
She's going to tell us what she's feeling too. She's going to capture the whole experience.
See, so he flips it and then pushes it against his stomach because he doesn't have 3 hands.
Now, what are you feeling? What is it? Yeah, chest tightness.
Oh, thanks.
Read the title of it best. And now it's still high, but it's below the 150. So it's decreased it quite a bit.
You didn't P-wave that.
And we got P waves.
All right, so what exactly did you feel? Yeah. So was there like a burning, a cramping, a pressure, an aching, stabbing, jabbing, knife?
No, it's not like a burning feel, but it's just, I guess,
not like really, it's like tasting medicine, but I could taste it like in my mouth. You could taste it. Was it painful? No, it's not painful. It just felt funny in your chest. Mm-hmm. It's a funny feeling. Then when the medicine gets through there, everything just calms down. I'll be all right. All right, so it looks like your heart rate now is down to like 113 up here on the monitor. We got P waves. Here's a new EKG on you. And
okay, and she's healed. So this happened to her. If you were her nurse, and this just happened, and you're caring for her, like say this happened in the ER, and she gets admitted, and you're caring for her, what, knowing this little bit of history that this guy took from her, what would you suggest happen? This isn't her first time. Right. She probably needs some meds. Okay. The only thing she was on was what? Calcium and thyroid medicine. This isn't her first rodeo. So maybe we should get on some meds to control this stuff. So, and there's lots of reasons why she maybe wasn't. Like maybe she didn't follow up with a cardiologist. Maybe she didn't have money for the meds. Maybe they were just like, yeah, you're fixed, peace out, and didn't care to follow up. So lots of reasons, and it's your job as a nurse to figure out what those reasons are, pass them out, and to pass it on. Okay, calcium channel blockers. So the other one, the angina, right? We had the nifedipine, the verapamil, and the diltiazem. This happens every time, doesn't it? Like I get tongue-tied at the end. For dysrhythmias, we're just talking about diltiazem and verapamil. Okay? Blocks the movement of the calcium. We talked about that. Slows the conduction. Leads to decreased heart rate, decreased excitability and contractility. Used to treat CVTs with the A-flutter and the AFib. So here's kind of both of them. This has a lot of drug interactions too. There's your AV block, not to give with it, all the side effects, so on and so forth. Any questions on this? Okay. Please note, all antidysrhythmic drugs are potential pro-dysrhythmic. What's pro-dysrhythmic? They're going to cause either a new dysrhythmia or worse than the dysrhythmia. It can just be bad. Okay. In some cases, taking these medications, life-threatening ventricular dysrhythmias can result from even appropriate and skillful attempts at drug therapy. Okay. So even if they're on an appropriate dose and we're trying the best we can, these life-threatening ventricular dysrhythmias can happen. And then very important for patients, like with her, if they start her on this lady here, they'll probably admit her, start her on a drug to help control, but she'll be kept in the hospital for a couple days, monitored to make sure that drug is working and it's not causing any of these other dysrhythmias. Okay, so cardiac monitoring is recommended when initiating these types of medications so that any adverse reactions or new dysrhythmias can be caught. Okay. That's just your list of meds. That's all you need to know.
Like for real.
Like goes down the street and through the halls. I like that. Okay. You guys have any questions?
Probably.
Okay. Well, if you do, message me, text me before the test. Okay. Let's see. Hold on one sec. Now, I gotta get to this real fast. Our learning activities. Who has their phones? Huh? No? We're doing Cahoots.
I love Cahoots, but we need to do it because she needs to run a SCT anyway. So this will be it. But just being
CP waves will get, all right. Well, that was.
Pre-workout?
Okay, let's see.
Mark, we're good looting.
I'm sorry.
Oh, sorry. Get out there.
Yeah.
Okay, give me just a second.
But like emergency, so I'm like all amped up, and then it's like, oh, you're taking my truck in. It's like, okay.
Hey, Corby.
Yeah.
Do you know any stats yet about your test?
Okay, so right before we started, I quickly jumped on. Now, I don't know where Debbie is with adjusting and grading the math and stuff, but both online and in class had an average of 86%. Wow. You guys did awesome. Like, I am so proud. So I'm crazy excited about that. That's great. Hold on. Let me just finish this up and then we'll get this going.
I wish we could explain our rationale sometimes.
I can understand that.
This is why I got that answer.
This is why I did this.
I mean, it's right, but.
Okay.
No.
Technically.
Why'd you do that? I don't know. It's all right. Little South Chantel makes me EKG tech. I was like, I don't know what anything meant. I just knew it didn't look right. So.
Yeah. Like the one that said enter game computer. Let's play.
Okay, hold on. Okay, I'm gonna go out real quick so I can share this screen with the online peeps, if I can find it. I don't have to play. They need to play.
I just jammed this, like, actually in my car. You kind of driving, be like. There's a song.
Oh, here we go. I found it. Hold on.
Yeah, well, kind of. He doesn't swear once. It's just like raw. My son will take this to the Mexico.
Yeah,
Bring
starts
go around.
screaming at the end.
Bring around. 1, 2, 5, 2. I did it right.
Okay. I want to turn. Can I turn this down? Okay. Now, guys, I have for the winner a chill pill stress capsule. It's like a stress ball, but it's a capsule. It's a tablet. So whoever wins gets this, online or in class. Doesn't matter.
That sounds fake.
Oh, shut up.
Yeah, 27 people. Is that it?
What?
Aw, frowny face.
No, I watched Pokemon, okay?
I watched Pokemon too.
Read the book. You guys are awesome. Kamehameha. Okay, I'll give like 30 more seconds and well, you gotta get going. Wait, I'm losing people. Why am I losing people? Hurry, jump in. You don't play the game, you can't get this little guy. Okay, there we go. All right, everybody in here anyway? Okay, here we go. We're gonna start. Okay, start cardiac stuff. Hopefully this. Is that everybody?
Yep.
Hypotension.
I knew that.
So here we've got the nitroglycerin you're giving to somebody with a blood pressure of already 100/60. We don't know what their heart rate is. It could be 112. Nitroglycerin isn't going to affect the heart rate. It's going to vasodilate, which is going to affect your blood pressure. Okay?
Leslie, too cool for a nickname.
Beat Liv is on the tail. Can you guys see that? I hope I'm not in your way. I can try to move this. The cord is so short though. Oh, what did I do? What did I do? Oh, sorry guys. I'm so sorry. Hey, you all got that. Woo, good job. Oh, beat Liv in second. They're tied for first. I do have two. If you guys tie, I do have more than one. Mark, I don't want to be in your way.
Totally fine.
Sit down.
Okay, now we're talking about digoxin. One more person. Okay, that's your heart rate. Digoxin's your heart rate, right? You got to check your apical heart rate. If it's too low, 56, you got to be careful with that. Oh! She's fallen off the board. Okay, now we're talking about lab results with digoxin. And just so you know, the picture pictures have nothing to do with it. I just didn't want it to be blank.
So we're like, no, and I'm like, oops, my bad.
Okay, so which one are we worried about? Potassium. Okay, so the ditch level is, what number are we looking at? 2.0. So this is 1.8. We're still okay. So it's the low potassium, right? Because that can cause toxicity. Okay. Good job. Feet lift still up there. And the big BS. You guys have got the podium. You're staying there. Oh, sorry.
Sorry.
So this is the most common response by the patient when administering inguinal drugs. Hypotension. Okay. Any questions on that one? Oh. Okay. Good job, guys. You guys are doing good. Okay, when are we going to call the doctor and give him nitroglycerin?
I like was distracted.
Good job. Persistent pain, that's when you call the doctor. The other ones are just side effects and they're expected, right? Ooh, Vic is on fire. Is that Victoria? Woo woo.
Whoa.
Okay, which one's a calcium channel blocker? Remember the very nice drugs, calcium channel blockers.
Oh, wait, I actually might have gone right. I'm gonna guess
Heck yeah. Okay. Ooh, Lena's getting up there.
Yes.
So we're talking about which beta blocker would you give a patient with COPD?
I forgot already.
Okay, here's a tip for you guys. They're all beta blockers, right? Do you know what Nadolol or Pindolol are? Have we ever heard of those? Right? So even though they're beta blockers, count them out. We haven't talked about them. So that's probably not the answer, okay? So don't get hung up on drugs you've never heard of before. Propranolol is non-selective. Okay, Lena's getting up there. She's on the top now. Okay, somebody's taking meds for heart failure. How do you know it's going to work? Or how do you know it's working?
I like the damn.
Hello, avocados. They're so yummy. Okay, good job. Peripheral edema is decreased or absent. What about urine?
That's not enough.
That's not enough, right? You got to have at least 30 mils.
I hit that. I was like, that's not enough.
30 mils out for an adult per hour, not 4 hours.
I stopped peeing.
Oh, Lena's, look, she's got a 400-point lead. This is based on speed too.
Some people are fast typers. Yeah, I'm not one of them.
Oh no!
That was stressful. That was way stressful. We all knew who's gonna get there first.
Look at the back. Wow, anti-anxiety meds. No, it's not.
Good job. It's high. Anything above 2.0.
I've literally been behind this entire time.
Lena is hold tight. Second and third keep moving, but Lena's got it up there on first. What's the symptom of heart-sided heart failure? The right lobster, not the left lobster.
What? Lobster.
Oh, there's lobsters up there. That makes a lot
The pictures. Good job, guys. Peripheral edema. Oh no! Lena was dethroned.
Don't blow it, Taylor.
You only got 3 more. Keep it up.
Oh, I just picked one, but I don't think I read either.
I just said don't put the green, so I don't know.
Okay, here's another test tip. If you see one, but you see an opposite, chances are it's going to be one of these.
I meant to hit that one.
Okay, probably not going to be one of these. You have decreases heart rate, decreases contractility, decreases heart rate, increases contractility. It's going to be one of these, more than likely, if you see opposites. Okay, here we go. Oh, Vic is back up.
You do a great kind of thing.
Taylor, you're so close.
Oops, I did that wrong.
Take food alcohol.
We need an appropriate nursing intervention.
Yeah.
If I would have read, I'm like, I'll find nitroglycerin patch. I'm like, thanks, scary areas. My kids for a long time classified them.
Okay, good job. Have patients sit or lie down. You don't put patches on hairy areas. Any patch is not on a hairy area. Doesn't matter the men. Oh, so close. Taylor, you're really like only a few points away. You got 2 more.
Too much of all.
Oh gosh, dang it. That's the heart.
That's absolutely true. Absolutely true. Good job, adenosine. Atropine is for bradycardia to bring up the heart rate.
Oh!
Okay, here we go.
All you gotta do is just get it right.
What?
You didn't get any points for the last one.
No, you didn't, because I couldn't put a right answer. Because you guys could honestly like hate pharmacology. I couldn't give you.
Yeah.
Go take a picture.
Where's the Tiny Tay? Tiny Tay.
Okay, I'll put that up. I'll share the Kahoots if you guys want to do it again. I'll share it. But only for today. Because those who didn't do it, there were like 6 or 7 people that weren't on there. So they still have the rest of the day to do it. Okay, that's it.
That's on.
All right. Let me know if you guys have any questions or need clarification, or if I did something wrong on the PowerPoint. That's happened before. Okay, we good? Oh, a poll. That's right. Okay. So I know you guys took that survey, and people online can chime in too. Oh, wait, hold on. We need to just do this. Okay. So, oh, dang it, put me again. So let me say that again. I'll make this Kahoots available for the rest of the day so that people who weren't able to do it with us have the rest of the day, because that's our learning activity. Anyway, I know we took a survey last Friday. I'm getting mixed reviews since then about our team teaching. So what are your thoughts? Helpful, not helpful, confusing?
I think it's helpful because it's like
Taylor's like very.
Yeah, heads up, 7 up.
Yeah, you can do that. Yeah. Do you want to do that?
Can there be like a midline, like I like both teachers, but I don't like you teaching at the same time?
Yeah.
Like I like team teaching, but I like separate team.
But not at the same time.
Can we please do heads up, 7 up? I love heads up, 7 up.
Yeah. Okay.
It's been like 15 years.
Okay. So everybody, put your heads down.
Hey, I'm sorry.
Okay. We're really doing this for just a hot second. Just a hot second. Okay. Put your, or do that. Put your heads down. I'm going to give you 3 options. Okay. No, you put your hands up. Okay, here are your 3 options, just so you know what they are. Helpful, not helpful, or what Stephanie said, like the team teaching, but not together. Does that make sense? Yeah, together separately. Okay, so how many people think it's helpful? I have like iffy hands. It either is or isn't. Okay. Who thinks it's not helpful?
We're also doing it on the chat, so you know.
Okay. They have all their heads down. They shouldn't see anything. Here, I'll do it this way. Sorry, give me 2 seconds. Okay. This is the not helpful one. Okay, and then here's the together but not together. Yeah, did somebody vote twice back there? Okay, perfect. Yeah, we're done. Okay. Perfect.
Yesterday, I'm not even sure I napped. Like, I went in there yesterday for lunch, was laying on the floor, put some meditation off. I don't know what happened, but I felt better. I was like, did I sleep?
You guys, I really did enjoy teaching in person. This was honestly my first time teaching pharmacology in person. Because all last semester we were online too. So I really enjoyed it. Thank you. Okay.
Hey, I want to go on the bike ride.
We'll see you guys later.
I don't know. Everybody's got bike shorts on.
I want to play. I'm biking.